My microphone is not working.
It's working.
Is it?
Yes.
Oh, I'm just so used to this. Good morning. How are you? Are you feeling healthy? Eat healthy. Did you have a good night? Did you play Harbour last night? Yeah, amazing place, isn't it?
Yeah.
You didn't have too much fun.
We are ready for very serious discussions now, but some very serious information again this morning before we start to feel safe here.
Welcome to the conference. Before kicking things off, we would like to take a few moments to go over some important safety instructions. To ensure your safety and well-being, the conference area is secured by the Estonian police. In the case of an emergency situation, we kindly ask you to follow their safety instructions. In the case of an emergency, we will sound an alarm. The alarm will ring continuously for over a minute, or will be activated twice within 5 minutes. After the alarm, we will initiate the evacuation of the building, and you will be required to proceed to your nearest exit. Please take note of the green lit emergency exit signs around you. There are 4 marked exits in the black box. 2 are located along the back wall and a further 2 on the left and right. There are 13 emergency exits out of the building, 11 of which are located on the first floor. Once you have exited the building, head directly to the designated assembly point, which is located behind the building, on the pedestrian walkway near the parking lot. In the case of an emergency, we would ask that you remain at the assembly point until every person has been accounted for and you have been cleared to leave by the rescue workers. And with these simple and easy steps, we conclude our safety announcement. Thank you for your attention, and we wish you a safe and pleasant conference.
So we hope this never happens, but to be secure. So, who are we?
My name is Marjo Näkki. I'm a Finnish journalist who calls this Tallinn her home, lives now in Moscow. I'm a Moscow correspondent for the Finnish broadcasting company YLE News. And who are you?
I'm an Estonian journalist. I was a correspondent in Moscow 2 years ago. I was in New York for 20 years, and I was an anchor for the news in Estonian television, now a freelance journalist. And before we start the actual debate, we have some more reminders, because we feel here like people who have to remind you everything what's happening in this building. So first, there are 3 sessions, 3 rooms where the sessions take place in this building. Mario, where are the rooms? First here.
This is the engine hall, and you can see on the screen where you are. And then downstairs, there is power station and steam room. And you have living signs and signals helping you out as well. And then we have breaks as well.
Yes, downstairs it's the main hall where you entered. There you have all the breaks. There you have toilets. There you have breakfast. There you have exhibition. So that's the main place to socialize and communicate.
And of course, we need to be online all the time.
The conference is paper-free.
Yes, true.
It's fitting for the e-health conference.
And the Wi-Fi here is called Free the Data, and password is Fifth Freedom, because this is one of the goals of Estonia's presidency, the free flow and secure free flow of data.
And we welcome your feedback to the conference. Please go to delegate.eu 2017.ee and then say what you think of these discussions.
And remember to tweet on Twitter, #eHealthTallinn.
As those big chairs here remind us, the conference is about future generations, how we're building the future for them. And we start this second day of the 3-day conference with a small reminder of our future with some Estonian Nordic humor, we hope.
The future is already here. Our children are the users of the digital services we create today. Personal health data. You decide who has access to your sensitive health data. You choose who can see and use it.
And now it's time to start the actual discussions. And the centerpiece of our conference here in Tallinn is the signing of Digital Health Society Declaration. To introduce the declaration, we invite to the stage a very excellent panel led by Aina Aaviksoo, who is Deputy Secretary General for e-Services for Information and Information in the Estonian Ministry of Social Affairs. So, Mr. Aaviksoo, please come to the stage and you'll be one of the host for this conversation that will follow. And also on the stage will be hosting this discussion is Mr. Brian O'Connor, Chair of European Health Alliance, digital expert from Northern Ireland, with great touch of humor of Ireland, as we saw yesterday. These will be your moderators for this following sessions. And the panelists.
From Netherlands, Erik Gerritsen, Secretary General from the Ministry of Health, Welfare and Sport. Welcome to the stage.
Dr. Angela Brand, Director of European Centre for Public Health Genomics, please.
And straight from Wales, Blythin Rees, digital health expert and lawyer, Osman Clary. Welcome.
There you are, Eric.
And Mr. Richard Corbridge,
Hi.
Health Service Executive from Ireland. Have a good discussion, and we'll be back to introduce the signing ceremony that will be held on internet as fitting for this conference. Please.
Okay.
Thank you, Nem and Mario. Please raise your hand who was in Malta on 10th of May. Well, great many of you. I remember it was 19 degrees outside, and 2 days before, when I left Tallinn, it was freezing. It was -5 in the morning. And that was quite a shock to have this summer arriving so early. And then I also remember that we were preparing our presidency, and of course, these 6 months that we had to start earlier due to voting in one of the EU member states made us to innovate, to be inventive. And so we came up with the idea of ad hoc meeting in Malta. We booked a small room just to discuss the idea of Digital Health Society. And the first 15 minutes of the meeting, we had to bring more chairs into the room because we couldn't fit in everyone who wanted to hear what is now happening. It was 160 days ago. And what a ride it has been since then. I'm genuinely pleased to have you here, but you will probably tell that there have been many, many people who have felt that this is probably something that we can introduce in addition to what we have already in our e-health landscape in Europe, in order to make progress faster than we have made so far. Because the feeling, this feeling that made people come into the room and so that we needed more chairs, told us that probably people are really desperate to do even more that has been done so far. Today, we can tell that there have been task forces. There is a declaration. I've been whispered to my ear that actually some organizations have already started to sign it, so signed it. We will continue it from here. It will be open to everyone and all organizations in Europe who feel that this is something they want to endorse, to tell to the ministers, but also all other stakeholders, we want better health systems with the help of digital technologies. We want better and more intelligent health systems through research and development using data which people voluntarily are donating because they want also better health systems, they want better solutions for them, and we want our European economy to develop and prosper in addition to all other things that we do already, now also through making use of all the health data. And this is what the Estonian presidency has been striving for, and this is why we are so happy that there are so many people and organizations who support it, not just with their word, not just with their will, but we will hear today that also with their action. So Brian and ECH Alliance have been, in the sense, instrumental in helping this idea. It was really first just an idea to become a reality. So maybe, Brian, you can tell, how did you make it?
Well, I think it's a we. How do we all make it? And I think that we'll hear this morning from the task force leaders who, of course, represent other groups who gave up their time during what for most people in Europe is the sacred time of the summer holidays and still produced, as you'll hear, great first steps, as I would put it. And I don't want to steal the thunder of the task force leaders because they're the people who've been doing the work. What I would say to you is this, and again I repeat what I said yesterday, this is about citizens, it's about you, me and others. And it's really about making sure the citizens have their voice. And when you look at the digital single market, the review of the single market, the consultation of that market, which just finished on the 12th of October, we're looking forward to hearing the results of that from the Commission so that we can try to continue to support the Commission's efforts to make the digital single market real for us. Because often these policies and so on seem distant, something we can do nothing about, but which always affect us. What I'd like to see is a movement which starts to affect the policies, that starts to shape those policies in the future. And it's up to you all to use all the power that you have in this room to ensure that your organization steps up as well, fulfills your own duties and responsibilities to your employees, your citizens, your staff, their families, and so on, and utilize the idea of a digital health society, which you will see as we move along, focuses on people. We all know about the policies, we all know about the technologies, we all know about all of that, absolutely vital. But the fundamental is for all of us to be able to live better, look after our families and others better. I have two grandsons who are 16 and 13, and they think they're already in the digital society, just as the little video showed. What we need to do is make sure that healthcare stops being the one sector that doesn't seem to yet have succumbed to the consumer demand and power. And that's what irritates me, as you probably gather, that we seem to be the only sector that is still holding out against the forces of what I consider to be good. So it's up to you as well as us. We can do what we can do, but we can't do it without your genuine support. And the last thing I'll say is this. Signing the declaration is not, we're not here. Someone asked me this morning, what's your target number of signatories? Answer is we don't have one, and we shouldn't. This is not about the number of signatories. It's about the people who sign and why they sign. And Eric will speak to us shortly about his views on what it means to sign a declaration. Because we all sign lots of things, don't we? And then we forget we've signed them. And so I want our panelists here today to explain why you should sign, but only under certain circumstances. So I'll leave it at that for the moment, and over to you.
Yes. So let's hear what the Digital Health Society is about in a content. It has been support to our policy, and we have 4 distinguished people who, as Brian said, spent their precious time and also made, through their leadership, all their team members and people abroad to work with them because they believe in it. So I hope they will make you also believers in the Digital Health Society. So Eric, over to you, please.
Yes, please.
What is the task force number 1?
Yes, number one. Herco will assist me. So thank you, Ian, and thank you, Brian, for giving me the opportunity to share with you what we already have achieved and what we hope to achieve with the Task Force of Interoperability. I'm wearing my pink socks.
Yeah, we all wear your pink
In the
socks.
spirit of sharing. If you don't have them yet, try to get some, because then you are a member of the secret society. But ladies and gentlemen, let me just start with a little video that explains why we are here today.
Mensen met de chronische longaandoening COPD moeten regelmatig naar het ziekenhuis voor controles en behandelingen. Deze bezoeken zijn voor de patiënten erg zwaar vanwege hun beperkte longinhoud. In het oosten van het land is daar nu een oplossing voor, de dienst COPD in beeld.
En u voelt zich verder goed? De grote voordelen voor de patiënten, maar ook voor ons, zijn eigenlijk dat de patiënten gezien worden op het juiste moment. Dat ze een longaanval hebben. En dan kunnen wij in een coachende rol, waarbij we echt de patiënt echt letterlijk in beeld hebben, heel goed met de patiënt meekijken wat er aan de hand is. En op dat moment ook de goede interventie plegen. De eerste resultaten zijn dat het met de patiënten gewoon goed blijft gaan. Dat ze minder in het ziekenhuis komen voor opnames en minder voor polykliniekbezoek.
Met COPD in beeld sturen de patiënten 2 maal per week hun waarde door met de C-Vitals-app van Focus Cura op een iPad. Deze worden gemonitord door gespecialiseerd verpleegkundigen op het Medisch Service Center in Varsseveld. Is er een afwijkende waarde, dan is er videocontact met de patiënt of kan de longverpleegkundige worden ingezet.
Het voordeel van deze werkwijze is dat de patiënt nu alleen maar ziet als er ook echt wat aan de hand is. Het Medisch Service Centrum heeft de klachten al gefilterd. Ik kan direct contact opnemen via het videobellen en kan zien wat er met de patiënt aan de hand is. En samen kunnen we kijken of de klachten kunnen beperken.
Ik hoef minder vaak naar het ziekenhuis toe, wat voor mij echt een zware belasting is. En ik heb het gevoel dat ik 2 maal in de week word ik toch gecontroleerd, wat veel rust geeft voor mij en voor mijn familie.
Het Slingeland ziekenhuis in Doetinchem en thuiszorgorganisatie Sensieren werken al een tijd samen met zorginnovatiebedrijf Focus Cura aan de ontwikkeling van COPD in beeld. Vanaf het nieuwe jaar komt de dienst breed beschikbaar en wordt deze bovendien volledig vergoed door zorgverzekeraar Mensis.
Met COPD in beeld kunnen patiënten langer thuis blijven en thuis behandeld worden. Dat is voor hen beter en voor ons allemaal, omdat er meer mensen geholpen kunnen worden voor hetzelfde geld.
Ik denk zeker dat het een uitkomst is. En zeker gericht op de toekomst.
Het aantal mensen met COPD stijgt snel. De Wereldgezondheidsorganisatie voorspelt dat de chronische longziekte in 2020 wereldwijd de 3e doodsoorzaak is. Met de financiering en opschaling van COPD in beeld neemt Nederland op het gebied van innovatieve COPD-zorg een koploperspositie in Europa.
Right, ladies and gentlemen. The Digital Health Society is not about the future, it is about the present. And I'm here because people like Mr. Bremer, nurse specialist Spekschoor and pulmonary nurse Sveers need us to break down barriers and that prevent them from communicating in a modern and trustworthy way. That prevent them from having the right information available at the right time and at the right place. That prevent them from delivering warm care in the patient's living room using cold technology. That prevent them from using e-health solutions just like regular healthcare. And that prevent them from being the masters of their own health and equal partners in managing healthcare. Home care organization Sensieren, digital care provider Focus Cura and the Slingeland Hospital and Mensis Insurer show that it is possible. They are an excellent example of what I call a coalition of the doing. And in the Netherlands, we work hard on creating a flourishing ecosystem for digital health solutions to grow and become a part of regular healthcare. And any ecosystem requires 2 things, a good climate and fertile ground. And we create a good climate by giving solutions like COPD Insight a platform to scale up from 1 home care organizations to more, by bringing innovation, best practice and skills to healthcare professionals. And the fertile ground is the foundation on which this modern healthcare is built. It is the standards and requirements and legal frameworks that ensure that all communication is safe, secure and trustworthy. That we know who are we communicating with. That our communication has not been altered along the way. That we understand what we actually mean. And that we can use the data in our own personal health environments. Interoperability is the most fundamental requirement for the success of digital health. And that is why we lead this task force. We believe that the way to achieve this is by creating a movement. And I've borrowed this video from the popular TED Talk by Derek Sivers on how to create a movement. He describes a process where a single person with a disruptive idea or action does not make a movement. It's the first followers who join this first initiative that transforms the lone nut into a movement. The movement grows stronger and stronger as people join in and add their own contributions to the group. And the Digital Health Society initiative can be such a movement. It brings together different people and organizations that share the same ambition, to become part of a coalition of the doing. And our contribution to the Digital Health Society is to create a movement in interoperability. Our ambition with this task force is simple. Start by sharing which interoperability standards we are using, those that actually work. And we start this movement as the lone nut, by sharing with you interoperability standards that are effective in improving medication safety. Lack of up-to-date information about a patient's medication causes 75 people to be admitted into hospital every day in the Netherlands. And this is a real interoperability need that can be solved by using standards. Currently, a coalition of general practitioners, pharmacists, patient organizations, hospitals, care delivery organizations, and their IT vendors are implementing these standards after having proven that they work in a local setting. And additionally, we made available a list of 67 standards that are currently in use and have been fully adopted by the healthcare providers and their IT vendors. And this movement already has a few first followers. The Danish Health Data Authority has shared their extensive standards catalog, which contains over 200 standards and their status. They have also shared their reference architectures for clinical document sharing and citizen health data collection, showcasing how standards work in those use cases as well. And the Greater Manchester area shared their list of standards for their DataWell health information exchange platform. But inspiring as these contributions are, we are not a true movement yet. And to be honest, I'm a bit disappointed at the response so far. How difficult can it be? All we ask is that you simply share what you're already doing. And if you cannot do that, perhaps you should have a look in the mirror and ask yourself, am I a true leader? So here I'm standing before you, still feeling a bit like a lone nut. Ladies and gentlemen, I want to challenge you to follow this lone nut and become the true leaders of this moment, of this movement. Because as you know, the real morale of the story is that it's the first followers that create the movement, who are the real leaders. And it's super easy. All we ask is that you join our task force and share which standards are already in use and what for. So we can map which standards are used, where, and showcase matching standards. And thus we create the bottom-up, de facto European standards, building the fertile ground that is fundamental to making the European health ecosystem flourish. Join us later today at the session on this task force, and together we can create a true coalition of the doing. And if you don't want to do that, then don't sign the declaration. Thank you.
Well done.
Well, thank you, Eric. Thank you for inspiration, how to create a movement. Well noted. And I hope that we will get the followers, as you pointed it up. So, Brian, who's next?
I think Angela's next, I think.
Angela.
Yeah.
Well,
there you go.
What kind of movement are you creating?
You can speak about you got there.
First of all, thanks a lot, Ian, for this really great initiative and the chances to be creative, think out of the box in the task forces. Our task force, Data Donors and Citizen Control, Data Governance for Secondary Use. Where we are. we have the technical solutions and tools. We have Bitcoin, we have blockchain, we have sandbox, we have artificial intelligence. Then the European Open Science Cloud is coming, and then something like the Integrated Healthcare Enterprise Standard, which had been already introduced in more than 60 countries all over the world. Then we have a political commitment, strong political commitment and tools. So whenever we look at policy papers, we see the citizen-centered approaches. We have the concept of the health in all policies. It had been developed under the Finnish presidency, I think 11 years ago. And then the health in all politics following that. We have the cross-border directive, a healthcare directive in place where data follows the person. And then recently the B20 recommendations to G20, the policy paper stepping up the global health, so it's a policy paper from May this year. And then we have European frameworks and principles in place. For example, the 4 common values and principles in the EU healthcare system: solidarity, universality, access to good quality care, equity, which had been described in the strategy Together for Health already in 2007. But then we have also more general on European level, the 3 core principles, again, solidarity, but also subsidiarity and proportionality, I think, which is one of the strongest maybe in this context. And then Brian mentioned it, what we have now, the digital single market strategy, where explicitly it says it's required the access to own health data. And then Horizon 2020 was an IMI initiative, especially I'm thinking about. And then the big Estonian presidency goal, the 5th freedom, EU freedom, digitalization and gigabyte society. What needs to change? What we see as there is a need or demand for health data governance. But what we see is that the governing models we see so far for better health and healthcare are based on an outdated assumption of data protection and data security. We are obsessed by this mantra, I would say, and there are other ways now where we think that fit really to our times in the digital world. So these models doesn't work anymore, and we have to come up with a new good governance model. So what kinds of good governance model do we need? What are the characteristics? A governance model for citizen-owned and citizen-controlled data, allowing for both, for the free flow of non-personal data, but also to provide access and reuse of data for future known, but also for unknown future purposes. And also it goes beyond health data and IT solutions for health. So going beyond these silos. Also understanding that data are an essential part of health research, of healthcare, of health improvement and health systems. And that also these governance models have to be in line with the forthcoming EU Commission policy paper on the transformation of health and care in the digital single market, and also to the Cloud Council recommendations, which are coming soon. So what we worked on is really to provide a solution. What could be a best practice in that field? And we came up with a solution that we need a pan-European good governance model, putting the citizen in the driver's seat to make best use of the technology innovations so that they become a social innovation, and all kinds of data, health data for individual benefit and the common good. And we think these would be a health data cooperative, or data cooperative, but starting with the most essential part, the health data cooperative. And that had been, for example, also mentioned in this B20 recommendations recently. That means that the citizen is the creator, is the nature interpreter, is the controller, the owner, the sharer of the data for primary and secondary use for all kinds of purposes in a trusted entity, and even beyond, going beyond the healthcare sector. So the definition, just to say that, is from the International Cooperative Alliance of a cooperative is that it's an autonomous association of persons united voluntarily to meet their common economic, social and cultural needs and aspirations through a jointly owned and democratically controlled enterprise. No? So also what we think, it is very much, there had been a very strong movement, the My Data movement, and there recently also had been the conference in Tallinn and in Estonia, where you have, on the one hand, you have the data sources, what you see here, you have the data using services, and you have an operator in the middle. And then persons feed the data into that operator. And in our case, we suggest that the operator would be the health data cooperative. Why a cooperative model? Why do we think that might be the best solution for the time being? So it's a truly bottom-up solution. The citizen is in the driver's seat. It's a truly democratic solution, not only for Europe, but also globally applicable. It can include all kinds of the various donors, not only the citizen, not only the patients, but also donors, for example, companies, industrial sector, administration, etc. Then what is essential characteristic of such a cooperative is that each member, each person has one vote. Data can be stored in intelligent cloud. It is an established model all over Europe, so all legal problems are solved, have been solved, and the citizen is at the interface. So the citizen is, one could say, the supercomputer, the holistic data integrator. All other technical, digital interpretations are just an approximation, but the real integrator at the interface is the human being. Then there is a possibility of the horizontal use of data, goes in line with the health policies approach. Then it's based on data commons, knowledge commons, commons arrangements, balancing personal benefit at common good, and it provides opportunity for many, many business models from the provider side, from the user sides, from all the kinds of different users as well, and useful for primary, secondary use of data. And also it complies with many, many existing very innovative initiatives, just to mention, for example, Takeda Pharmaceuticals or the oncology data in Europe code. And there's even a statute for a European cooperative. So next steps now are crucial is funding and pilots, and for example, funding smart cities, or we yesterday talked already with the European Investment Bank with Felicitas Riedel, then the European member states or regions themselves, then on Commission level, European Commission level, DG Connect, DG Santé, DG Regio, for example, and then also within IMI possibilities already the European Health Data Network as part of the Big Data for Better Health Outcomes program. And then what could be very concrete, because we had been asked actionable points, we had been very concrete, so pilots could be to develop what are the essential parts, a toolbox when I create a health data cooperative, then business-to-business money initiatives, virtual knowledge banks, for example, then cross-border implementation pilots, and then depending on different stakeholders' needs and local needs, for example, could be neighborhood management, hospital management examples, disease-specific patient groups examples, social networks, smart cities, etc. So I would like to thank all the members of the task force for really providing this input, and now the task force is open to much more members. Thank you very much.
So thank you, Angela. I hope you are getting a little bit of the glimpse what the Digital Health Society is. It is really pushing borders, but pushing borders in a concrete way. We saw how a suggested way to move forward with the standards and interoperability for a very, very clear set to solve specific problems, and then also how to give the power to the citizens to become their masters of the health, indeed through empowering them through very practical and already existing but not yet widespread use of data governance models where they are the owners of that. So, what is more to come, Brian?
Right, we're now on to the third task force with Bleddyn Rees from Wales. So I'd like you to have sympathy for him, but he did not make the World Cup playoffs.
Two.
Pink socks as well, but don't hold that against him. Bleddyn, over to you.
Good morning. And first of all, thank you to the Estonian government for this fantastic initiative. I've always, as a lawyer, subject to quite a degree of abuse from friends, family, and other things from my profession. But I've now discovered what my true description should be, lone nut. So I can readily identify with that. I'm passionate about law, about regulation. That might make me a bit sad, but I'm passionate in this sense. I believe that lawyers are not about what you can't do. I believe that legal regulation is about what you can do. Healthcare has, I think, suffered from constriction by laws. Data protection is probably one, GDPR is another, where it's been used wrongly on many occasions to stop the transfer of data. So this task force was really about how do we free it up. And before you worry, there are a lot of slides, but this is a showcase for the later task force session that I'll lead. So if you're interested in some of these, this is what we'll be talking about later at lunchtime. So why are we doing it? So the simple point on this slide is that the EU is not competent on healthcare in national states. That doesn't mean to say they're incompetent. It's a legal technical phrase, meaning they do not have the power to pass laws that deal with core healthcare. That is the responsibility of member states. So the reason that we have this task force is to address this problem. There is no power, if you like, to harmonize healthcare. Healthcare systems will only become sustainable if we actually learn from each other and we do not try to invent the wheel everywhere we go. So what were we doing? So our core proposition is that we will create, if you like, a law that sits above EU law, that is enacted by the voluntary signing up, as Eric was explaining, of regions that have the power over healthcare, like Catalonia, or entire countries. So the proposition is to establish a European health and care data convention. So that is the noble goal that we're about. So what might this look like? So the really simple objective is to create a set of common legal rights and obligations for citizens and patients. So if the starting point is that we all have the same rights in relation to health data, it's going to make it much easier for the regions and countries who sign up to the Digital Health Society to work together. So the fundamental building block is the idea of the convention. So the convention will be principle-based, and there are 9 principles that we have developed at a very high level. There is a lot of work to be done to articulate these in detail, so I'm just going to show you what these look like. So the first one is the duty to create and maintain an electronic health and care record. So really simple concept. The second one is that we have to comply with all law, so that would, for example, mean GDPR, and ethics for the healthcare professionals. So a really simple statement that's obvious, but that needs to be clear and clarified. Third principle is that as a citizen, you are entitled to access your record. In this context, for instance, I'm passionate about the fact that for my mother and father when they were dying, I needed access to their record. As a lawyer, I had an enduring power of attorney, so I could do that. But systems should be able to do that very easily. There is no reason why we can't provide that as a matter of right. We need to control the record, and a number of people have already referred to this. So principle 4 is the control of the record, and that's control perhaps in the context of every person who wants to access it, whether they're a doctor or a nurse or an administrator. And there are some complexities around here, around specific consent, implied consent, and in the session we'll be talking about that later today. So principle 5, communication and transparency. So this needs to be really clear what's happening in the system, who has what right, so that there are no misunderstandings. So this is another important principle. Principle 6, research consent. So this is the use of secondary data, the use of data to be developing new services, discovering causes of disease, and keeping people well. Principle 7 is the specific research uses that we're talking about again. And then principle 8, an important one, the duty to share health and care data and not be using things like GDPR as the reason not to share data. So this is another important principle. And then finally, principle 9, the idea of safe havens, so creating aggregated data across countries. So for instance, I get very frustrated that England doesn't have a diabetes register. Scotland has a register of 9,000 people. How brilliant would it be if we could combine databases in Estonia with the Netherlands, with Catalonia, with Scotland, with the Republic of Ireland. How much could we learn and enhance the development of research and services for people? And with that, there's some conclusions that I'll talk about again later, but that's it. So thank you very much indeed.
I must say that I spend a lot of time with Blethen, and I have a healthy disrespect for all professions, as you probably work out by now, and particularly lawyers, because I've dealt with them all my life. But I must say that it is refreshing to see the thinking behind the utilizing regulation and laws and so on in a way to benefit us, the citizens. And I think that's the theme that runs through everything that Eric and Angela and Blethen have talked about. So when I hear from someone who's actually been at the sharp end of delivering on an e-health strategy in the Republic of Ireland and also leading our this task force. So we're looking forward to hearing from Richard Corbridge from the HSC in the Republic of Ireland. Richard.
I'll run to the stage from the furthest away. Okay, thank you very much. Firstly and foremost, thanks to the Estonian government and to Ian. When we met in Malta and we came together, when you imagine a room that has standing room only, literally for 2 hours, as people volunteer to give up their summer to be part of a task force, you realize quite quickly that it's perhaps not just lone nuts, and that collaboration of the willing, and which became very quickly a collaboration of the doing, was something quite remarkable. We looked at digital transformation in Task Force 4, something that, let's face it, UK, the US in particular in recent years has been famously getting wrong in healthcare. When you look at the National Programme for IT, when you look at the different ways that organizations have tried to use digital to change healthcare systems, the transformation bit is where it's gone wrong. And I think when we came together as a task force, we were able to consider very quickly that there is so many lessons that can be learned from so many countries that aren't technology, that aren't about IT, that aren't about a chief information officer of a healthcare system, but are actually about clinicians and patients and making a difference. The digital experience of transformation is what we're here to do, not IT. And I think that was the thing that came strongest across our task force very quickly. How do we change this paradigm? How do we use an understanding of what patients need to truly change what we do? How do we improve the quality of life, reduce the cost of care, and continue to deliver patient autonomy? How do we do the things that were demonstrated in the videos where patients are now at home having care? Through digital is a way we do that. But the transformation to get there is perhaps the hardest to achieve, is perhaps the strongest way we can share experiences. Every country, every organization is spending money on learning lessons, but we're not finding a way to share. And the Digital Transformation Task Force 4 had objectives that were very much around how do we actually make sure that the transformation lessons that people have gone through can be learned. In Ireland, in December of last year, we opened our first digital hospital, a large maternity hospital in Cork. It took 9,500 hours of training across one hospital. Training in one hospital that we haven't shared with anybody else outside of Ireland. Training in one hospital that has been wrongly described as that training word, as that classroom sit and learn, when in reality, that training was transformation. That training was taking a 63-year-old maternity nurse who worked in ICU from paper on Friday to a tablet PC on Saturday. Transforming how we deliver care is a big part of where we need to go to. And the task force worked across a number of organisations, sponsored and run through an organisation called ARCH, which is the Applied Research for Connected Health part of one of the big Dublin universities. What that meant for us, though, is that this became a piece of learning that could be shared, a platform where people could deliver their transformation stories, their toolkits for transformation, and begin to truly put them out there for people to learn and share. As has been said already, we haven't been completely inundated with different experiences, but we have had a huge amount of advice and guidance that other people have picked up. Being able to create a fundamental checklist, a way of actually creating a toolkit that everybody can use. 3 fundamentals across there that start to actually change the way we consider how transformation can happen. One of the things that organizations try to do is create transformation before they've actually hit the checklist, the fundamentals that need to be in place. We can't deliver an electronic health record in every country, as Blended just asked for as part of one of their areas, without funding. So we need to ensure that funding, resources, capability is there in place. And actually understanding what that level needs to be to truly inform transformation is a big part of where we need to get to. The team then came together to create what we called an implementation interdependencies, a way of actually understanding the different things that need to be put in place. None of this is rocket science. None of this is something that people haven't understood before. But the big difference is that this is about sharing other people's experiences. Making sure that that large-scale transformation can be done regardless of the starting point, but by taking other people's toolkits and applying it. Learning cycles, making sure that that plan, do, study, act piece is there and can be put together and worked through as a way of delivering transformation. Tomorrow morning, myself and a colleague will talk through in more detail how that came about, what those interdependencies are, and how they're built. But effectively working through a different paradigm in how the different parts of an organization can become together. The macro, the meso, and perhaps, more importantly, the individual. How do we inspire our teams? How do we inspire clinicians, patient groups, IT people to come together and work through those different areas to ensure that readiness truly is there? We've looked hard to try and find out if other people have done this. So far, we haven't found this example coming together from anywhere else. It gives us a new compass, a new way of actually creating a business vision. Business is a dirty word in healthcare in many countries. We're not delivering a business, but you know what? I think it's time to get over that. We're not delivering digital healthcare. We're transforming healthcare systems. If we can hit that new compass, if we can change culture and workforce, if we can stop talking about a health strategy that doesn't have a digital part to it, if we can create a platform for how we do transformation and ensure that vision is there, then transformation starts to happen. And some of the parts of the toolkit through that new compass give us that. As with the others, we had a lot of help, a huge amount of help. Maria Quinlan from one of the big Dublin universities, Maria O'Loughlin, one of the people who's worked with our team, and a whole sway of people from across the EU came together to give us their examples of how to make transformation work. And that's what this toolkit now embodies. All those different organizations' willingness to give up their experiences of creating transformation. I hope that's been useful.
Thank you, Richard.
So thank you everybody for those presentations, and now it's time to actually sign this declaration.
Yes.
Mr. Avik, so how we will do that? I know it will be paperless procedure.
Yeah, well,
click.
There needs to be a...
What? A table, a pen, a paper?
No, we don't want a pen or paper.
It's the sewn paper and scissors. No.
So anyway, we know that this will be signed on internet.
And there should be a tablet to do so.
Well,
but anyway,
this is the new world, so something is missing.
it
But,
will come in a second.
Just speak.
so, but tell us in the meantime, what will happen next when it's signed, this thing?
Well, first, we started with the idea of having 6, 7, 8 task forces, and these 4 formed out of exactly as Richard said, will of people to contribute. And well, so that you know, Estonian government didn't pay these people anything. What we said in Malta was that, okay, we will offer a platform. We had a plan at that time already to introduce a discussion at the political level so that there would be council conclusions where ministers would sign and give political mandate to start executing things. And then we also discovered that, okay, there are probably civil servants, and I also belong to one of the groups in Europe called eHealth Network, where already several decisions are being made. We are currently preparing our multi-annual work plan. But then there is still a piece missing. We're missing a very strong support, not only about what could be done or what should be done, but really in the form that you heard here, that, okay, we can move forward faster. We have leadership which is capable of leading other people to the point that there is a clear plan to follow. This won't be easier, as we heard in the very last bit by Richard, that there is a transformation to be made. There is support that needs to come from different stakeholders. Doctors need to think their role differently. Hospitals and primary care service providers need to reorganize how they work. Patients, we are all telling, need to take more responsibilities, but again, they need to have tools. In order to become true masters of the health, they need to have, as we heard, also opportunity to manage not just their health, but also their data and the information around that.
So we still are looking for this tablet, but in the meantime, it's time to open this debate up to questions. So we are welcoming questions from the audience. We have several minutes for that, but maybe some first questions here. Ms. Brand, you described a lot of goodwill in Europe for this new declaration, for this new age. What are the main hurdles? How much resistance, how much healthy skepticism there is still in Europe for these measures? The microphone is right next here, right next to Mr. O'Connor. Yeah, please.
Thank you very much. Yeah, skepticism is, I would say, more barriers. Maybe skepticism is getting less and less. There's a momentum, I think, where really all the different mosaic songs come together. But there are barriers, I would say. And barriers are, for example, still keeping fields where not leaving my comfort zone, etc.
And still the belief that the paper is more secure than the internet. That one?
No, more from professionals, also to keep the knowledge, to keep the, I'm the owner of data from the providers, healthcare providers, for example. So that's a major barrier. And surprisingly for us also had been, when we talked to some member states, the doctors themselves, because we have a huge out-of-pocket payment a problem, I think, and we know that that drives really in the opposite direction. But to really have there more transparency, that's a challenge, a barrier. So I think that is maybe one of the major points.
Mr. Avikso, and then...
Yes, I wanted to resonate. The first, when we talked with Angela about the Citizen Cooperative, it had been in my head also for some time. And then I recalled one discussion that I had with one of the CEOs of a health insurance fund about a company that was offering a very nice artificial intelligence solution, the basic one that we have today, which is capable of helping healthcare funders to decide on cost effectiveness base what kind of treatment to provide and plan their resources in such a way. And imagine then an individual which we have seeing in increasing numbers who has more than one disease. And then from cost effectiveness point of view, we know that the resource allocations are being made. And then that individual happens to have 6 different diseases, and health insurance fund decides that A, B, and C would be cost effective to treat. And then if the same AI would be given to healthcare providers, and they also optimize their work, because some of our pricing models value from the provider's point of view some diseases over others. And then perhaps for a hospital, the disease B, C, and D would be most optimal to treat, which the artificial intelligence would tell them. And then at home, I have a wife who tells that, well, in most cases, or in many cases, not in most cases, in many cases, patients have, some itching, which is the most important problem for them. And perhaps for their life quality, the AI might tell that, okay, this is actually what you should be pursuing for. So by empowering patients the same way as health insurance funds and then providers are empowered, for instance, is the new kind of thinking that I hope the Digital Health Society will bring along.
Mm-hmm. Some short comments here, and of course, audience.
So a quick comment about the physical security versus digital security. A couple of years ago, my firm, we looked at the Information Commissioner's fines on the NHS in England. There were 21 in 1 year. 3 examples. The first one, they sold a whole lot of computers, didn't wipe the hard drive. Second example, they left laptops unencrypted on trains. Third example, they actually left a building, sold a building, left filing cabinets full of children's patient records. So the idea that this is a unique danger to digital is, in my view, a myth. I think second point about this free flow of data. What we've got to do is get real for me. We've got to explain to people what the use cases are, how they're going to get tangible benefit from some of the things that we're talking about. An example, you go in for a hip operation, so you're an elderly person. So for 6 months, you're not going to be very mobile. Wouldn't it be fantastic the day you get home from the hospital, that person receives a blue badge parking, which means that you can park in restricted zones. That's joined up government. That's what e-services are about. That's what's possible with some of the things I think we're doing. And in order to really get the movement going, whilst it's fantastic to get some of the research and other applications, the more that we can do simple use cases for you and I and our parents, the quicker society as a whole will jump on the bandwagon.
And one more comment here, and then the audience. Mario will lead that.
The skepticism does have to be got over, because if we don't, it will be done to us. And I think that's really important for us to realize now, that the Digital Health Society, the task forces that have come together, is about this willingness to share. If we don't do that, organizations we're trying to work with will do it at us, and we won't be able to come together. Something that Bledin talks about there, a real-life example. 2009 in Cork in Ireland, a huge flood. As is often the case, the papers are stored in the basement. A huge flood arrives, the papers are all wet. What do? We put them in a freezer, because we can't actually read the paper anymore, but legally we have to keep the paper records. They're in a freezer. No way of unfreezing them, no way of reading them.
Okay, let's unfreeze the audience now. There were questions, please.
Thank you. My name's Steve Barnard. I represent service providers in Europe. I've heard one person mention service providers, not just of the elderly, of people with cognitive impairments, physical impairments. These are people who are not necessarily patients. Patients are people in receipt of clinical services, and we seem to be talking about ill health, not health. And I think we really need to engage with service providers who have a great deal of authority, a great deal of control, and really are not interested in anything that's going on here at the moment.
And your question is, let's do it a very brief time.
Sorry, I've been working with them for about 14 years. Are you going to start engaging with them?
Can I take that one? Because I'm also a service provider. I've got an investment in a couple of service providers, because actually I think, from my point of view, that's where some of the money is. So just be clear, I do make investments. The reality is that the service providers themselves have a hugely important linking or connecting role to play in the connecting of services. Part of the reason why people have to talk at this high level at the moment is that unfortunately many governments, many regional governments and others are themselves silos often. and they see themselves as an illness or a sick service rather than a human service, a community service. So I agree with you. I think there's a lot of joining of dots, and taking Blethen's point, actually being able to digitally link and make people aware of you should have a blue badge, you should have the Meals on Wheels reinstated. There was a lady died in England only 2 years ago because she was discharged from hospital on a Friday night, given the money for a bus. She was 87 years of age, right? Went home for the weekend, died over the weekend because no one had thought to connect back in to the support service she had. That is not just bad, that is utterly disgraceful and a crime in my view. And it seems to me that we all, if we do actually get our heads down and do this together, we can stop that sort of horrible thing happening to us. What I'd move on to say is this. These task forces have done an amazing job. I think you'll agree that in a very short time, they've highlighted a lot of issues. However, there is a role for all of you, and I want to reiterate Eric's point. These task forces were closed to begin with to keep a small, tight team to work together. They're now open. We want you to join whichever task force you think is appropriate to your skills, your ambitions, your whatever. But I would reiterate, please don't sign the declaration if all you feel is you've signed a declaration and you want your logo there. We have enough logos, frankly, to do us for the rest of our lives. They don't actually feed us. What we want, all of us, is for whoever, when you sign, you are committing to do. I think this is a great phrase the Dutch have picked up, which is the coalition of the doers or the doing. So please do join us, but don't join us just for the sake of having your name and your logo up there. So these are now open. You can join. There'll be lots more over the next day or two of how you can
let's take some more questions. We are really running out of time. There's so much to talk about.
Gentleman over there, I think. There was lots of...
Please.
Thank you. Yeah, Marta Rosemuller, Yes, a Business School in Barcelona. I just have a quick comment and a kind of endorsement. First of all, congratulations to Ian, to the Estonian government, and as well the task force for this fantastic initiative. Angela, you had this whole list of different European initiatives. One important one is missing, which is EIT Health. And so EIT Health is an alliance, and some of our members actually sitting here, of companies and leading universities with the support of the EIT to move innovation in healthcare. So this is one of the KICs, the Knowledge Innovation Communities. And we are now starting, now that we have established ourselves, starting to look into what are the challenges of innovation in healthcare, and the digital transformation and big data has been identified as the first one we really want to look at. And so we have a think tank and a roundtable discussion on that. And I will actually bring or link that then to your task force, and we're happy to support and see how can we support this initiative, because I think what we need in order to make this true, to really bring this out there, is an integrator. And I think EIT Health would be one of those integrators, like probably the Connect Alliance and other things are integrators, to bring really all the different stakeholders together.
Thank you. And next question. There is a gentleman here.
Can I, in
yes,
between, very briefly comment back on both of those? So you very well noted that this is not a movement that is about to create new things in the sense that creating a project for providers. The idea is that during my traveling presidency and speaking 3-4 times with different people in different countries per week, I've discovered that there are so many initiatives happening. The providers are working and collaborating across Europe. Researchers are working and collaborating across Europe. Lawyers come together. IT people come together. And the discussion was that what can we do to bring now the governments and decision makers a step kind of closer to those initiatives that are already existing there, well, like EIT and all others, and then helping to gather this experience from all of those different projects and consolidate in such a way that the countries and regions who want to act and then take the next step once one problem has been solved could be possible, using the existing institutions, existing projects, but adding this momentum of getting things done.
Thank you. And now the last very brief question and very brief answer. No comments, just a question, 3 words.
Thank you.
No pressure.
Well, I'm a patient advocate from the Netherlands, having experience with cancer, osteoarthritis, and heart failure. My point is about the use case. The task leader of Task Force 3 pointed out clearly that we need to have tangible examples to have the audience convinced. Now, I want to flip the coin. I think it's not so much messaging to the audience, instead of the professionals learning to work with us as patients, right? Because we have lots of use cases which make the use of the flow of free flow of data, make tangible and the value immediately available. We have a very interesting cross-border use case available in which data from pacemakers, which are stored in Ireland, which I cannot access, which can be really useful for me if I want to see if my running training affects my heart rhythm, for example. I want to do my self-assessment and improve my life. So
And your
can we
question
use, please, these use cases and learn from that and use what it means for interoperability, for governance, for transformation. Thank you.
Thank you very much. And can I just, we agree, we are 100%. But what you've raised is precisely what we need now. It is now open. If you want to do something, as you clearly do, join the task force. Make your voice heard. Sign the declaration as well, but join the task force and say what you've just said, and we will find ways of at least trying to break down the current stupidities. They're not just obstacles, some of them are just stupid.
So by internet magic, all our panelists have already signed the declaration.
Think of
this
that,
is
you
the
see, no
screen,
iPads.
and now you'll see, look,
there you go.
all the signatures are already there, and as you see, this declaration is open now for signing to all of you. And please join the discussions. We have now a 15-minute break, and then we continue with the member states' response, because as we heard, EU doesn't have the power to regulate everything, so member states have to do a lot of things, and in 15 minutes we'll discuss that. Thank you very much.
Just before you go, can Ian just say a few words just to thank you all, please?
Yes, thank you. Joining the task forces means that we still have 2-3 months to work with our colleagues from member states and to channel this task force activities into decisions through eHealth Network, but also the continuation of Digital Health Society. And then all those who will join can, in the next phases, contribute to the actual implementation. And I really hope that the coalition of the doing by the governments signing that declaration and those task forces will start deliver and hopefully report you back in 6-7 months' time. Thank you.
This is the Estonian enthusiasm and Estonia's presidency. Thank you. Let's have some coffee.
We're back, and the discussion is back. We are continuing our e-health road here in Tallinn.
I hope your coffee was as good as mine. But first we're going to watch some children.
Again. For them, the future.
For them, yes.
The future is already here. Our children are the users of the digital services we create today. Secure digital data exchange. Transferring data digitally allows us to save time and money.
So in this section, we will look how the member states are actually running or driving on this X-road, as we call in Estonia, the digital world that is ahead of us. But first in this section, we have the view from the European level.
Mm-hmm. And as we saw in the video, that's again the fifth freedom, the secure and free flow of data, which is the backbone and most important thing in order to create and accelerate the deployment of digital health in Europe. And as a keynote speaker, we will hear from Commissioner for Health and Food Safety, Mr. Vytenis Andriukaitis. Welcome on stage.
Ladies and gentlemen, it is a great pleasure to speak to you today about digital innovation in healthcare and QA. You know, in my hands, Tallinn Digital Summit of 29th of September. It shows that Estonia is always about digital issues. It's very excellent, once again, to stress our attention on championing in this area. Whether we are healthy citizens or chronic patients, digital innovation offers solutions to monitor, prevent, and more generally, improve our health and wellness. First, I see huge potential in the digitalization of prophylaxis, promotion, protection, and prevention of health, including occupational health. Digital technologies help address mental, social, and behavioral determinants. A digital health society will bring more equal society and equality in health. Here, let me welcome the Digital Health Society Declaration signed at this conference. Second, I truly believe that digital technology can support to build sustainable, equitable healthcare systems that are accessible to all citizens which face economic challenges. Europeans are now living longer than ever before. It is estimated that we will have gained almost 5 years in life expectancy by 2030. High life expectancy is a positive achievement for society as long as we can spend it in good health. An aging society with chronic diseases and multimorbidity is actually a key factor in the rising cost of healthcare, which represented already close to 10% of GDP in 2015. Helping people staying in good health longer could help addressing the expected increase in spending. Thanks to scientific knowledge, effective treatment, and medical technology, what used to be fatal illnesses have become chronic diseases, thereby allowing people to live longer once they receive the appropriate prophylaxis, prevention, or often expensive, of course, healthcare treatment. The growing burden of chronic disease already accounts for up to 70 to 80% of healthcare costs in the EU. In response to these challenges, European Union member states are introducing new approaches and new models of care with the patient at the center. Digital solutions can fulfill an essential role in the prevention and management of chronic diseases by providing insight into our lifestyle behavior. This type of information can instigate change. For example, many smartphones come with a digital pedometer counting the number of steps you make, or can even register your sleep or diet. By providing more data and thereby highlighting what we are doing well and what needs to be improved, digital solutions can promote positive changes and support healthy lifestyles. Digital technologies can support patient-centered and community-based care and QA models. Mobile health apps and wearable solutions place the patient at the center of care. Citizens register vital signs and other indicators that could provide valuable feedback to health professionals. This allows health professionals to react more swiftly and more effectively when anomalies are detected. Furthermore, the use of digital solutions helps citizens living in remote areas to access health services more easily through, for example, consult services. Also, technologically enabled care involving the convergence of health technology, digital media, and mobile devices enable citizens, patients, carriers, and healthcare professionals to improve the quality and outcomes of both health and social care. These applications turned the healthcare sector into a data-intensive community generating massive volumes of information. Clinical, genetic, behavioral, and environmental data is generated from an array of devices, including electronic health records, genome sequencing machines, patient registries, and now data from mHealth apps. This data unlocks new opportunities for prevention and healthcare in the development of new therapies and precision medicine, and supports clinical decision-making by health professionals. Powerful data analytics can discover patterns that will, first, lead to new prevention, diagnostic, and therapeutic avenues. Second, help remove inefficiencies in care processes and reduce waste. And third, facilitate better management and clinical decisions that will improve the performance of healthcare and QS systems in terms of procedures, quality of care, patient safety, and patient outcomes. Ladies and gentlemen, the Commission carried out a public consultation on health and care in the digital single market that closed last week. Today, I am pleased to share with you the first results. Nearly 1,500 responses were recorded. According to the respondents, the most important tasks for the EU are, first, to develop standards for data quality and reliability. Second, to standardize electronic health records to propose health-related cybersecurity standards. And third, to support interoperability with open exchange formats. More than 90% of those who responded to the public consultation agree that citizens should be able to manage their own health data. Nevertheless, nearly 55% of the respondents indicated that they do not have access to digital health services. Nearly 55%. Such as remote monitoring and consultation with doctors, while more than 50% of those would like to have access to such services. So despite all the evident benefits to digital solutions, there is still a lot to do in order to realize the full potential of such innovations in health. Europe's fragmented markets and the lack of interoperability due to different standards across the EU are still a significant barrier to the successful implementation of e-health. The Commission has worked intensively with the e-health network to close the interoperability gap and to allow the exchange of health data across borders. Several European initiatives are already underway. Others will commence in the near future. In particular, the Commission and the Member States are finalizing preparations for the deployment of the European digital service infrastructure for the exchange of e-prescriptions and patient summaries. As many as 16 EU member states are involved in developing this infrastructure, and we expect the first exchanges of e-prescriptions and patient summaries will take place next year. By 2020, most member states will have joined the exchange, facilitating planned and emergency care across borders. The European reference networks launched this year are another excellent example for the cross-border deployment of e-health. More than 900 highly specialized medical teams from 26 European countries are pooling medical expertise and data to provide faster diagnosis and better treatment for patients with rare, complex, or low-prevalence diseases. These networks will be connected through a dedicated IT platform to be able to convene a virtual advisory board of medical specialists across different disciplines to review the patient's case. I see a lot of opportunities for more cooperation on European reference networks, colleagues. We can use them as a backbone for building a European health data ecosystem, sharing and pooling our resources, developing big data issues, and initiating better networking between and within member states' healthcare systems. Please take opportunity to be very active in this area. The 2015 Digital Single Market Strategy and its midterm review of this year call to accelerate the development and implementation of digital solutions in health. I greatly welcome that the Estonian presidency has made EU cooperation to support digital health innovation a priority. At the informal council meeting in July, health ministers articulated their willingness to be more ambitious on digital health and to collaborate more effectively on issues such as data security, cybersecurity, and new software products for data sharing. I take this opportunity to once again call on the member states to cooperate more energetically at a regional level, such as the Baltic Sea area, or the Mediterranean or Danube region. We need to show our political will to be more ambitious. The Commission is ready to assist you in this cooperation. We are currently preparing a communication that will take a fundamental step towards supporting member states in embracing digital solutions in health. The communication will be structured around 3 pillars. First, the pillar will focus on secure access to electronic health records and the possibility of sharing this information across borders. Next year, many citizens will be able to exchange their patient summaries and e-prescriptions across borders. However, we should be more ambitious and aim to share a more complete set of patient data cross-border and foster solutions which give citizens secure access to their health data wherever they are. Second pillar focuses on supporting data infrastructures for the purpose of research, prevention, and personalized medicine. Such data infrastructure and strategy will bring new knowledge for clinical care together with better diagnostics and treatment. This is particularly important for the European reference networks, colleagues. For infectious diseases, such support would enable the development of tools to improve the surveillance of outbreaks, for instance, risk models and relevant data meanings. Finally, data infrastructures would allow pooling and aggregating individual health data for research to understand how to use in a proper way all types of prevention, therapies, and technologies, including pharmaceutical products, at socially acceptable prices. The public consultation showed that almost 65% of respondents agree on the need to further develop infrastructure to pool health data and resources securely across the EU. And finally, third pillar will focus on citizen empowerment and fostering personal-centered care in support of the wider use of mobile health care and telehealth. Digital tools are an integral part of new care models to address the rising demand of health care. In the public consultation, around half of respondents report not having electronic feedback opportunities, while more than 80% agree that feedback to healthcare providers and professionals on the quality of their treatment is essential to improve services. Ladies and gentlemen, we have now come to a point where we are across Europe, confronted with common digitization challenges in health. At the same time, the recent public consultation showed that there was a very high level of interest and need for urgent European Union action in the area of digital health. Therefore, the momentum to converge our efforts has arrived. Let us all work together within governments, health professionals, businesses, researchers, local communities, but above all with the patience to make digital health in Europe a reality. Thank you, colleagues.
Thank you very much for this overview from the European level. It's interesting, I was talking, you may sit because you'll be one of the participants in our discussion after a few more presentations, but it was interesting, I was talking to Estonian entrepreneurs who are developing those new apps and services, among them e-death and e-birth applications and e-ambulance. You can hear about those at our session today, this afternoon, but they said the country closely resembling Estonia is Lithuania, the most closely, so we are both on the forefront of this new revolution. But let's continue now our discussion, and the view from Sweden is next. What has Sweden done in this field? Ms. Agneta Carlsson, please.
So, thank you, dear Minister, dear Commissioner, and ladies and gentlemen. First of all, I would like to thank the the Estonian presidency for the invitation and for arranging this conference. E-health and digitization is on the national agenda for my government, the Swedish government. And I'm happy to both share our experiences with all of you here today, but also, of course, to listen to and learn from colleagues in other European countries on what you have done within this field. Speaking about the Swedish experience of digitization, e-health and information technology in the healthcare sector is to share a very dual experience. On the one hand, Sweden has come a long way. We have one of the highest percentages of internet users in the world. We have given birth to startups that have become global brands such as Spotify and Skype. Both the business and the public sectors have largely digitized their activities, not to mention our tax service board that was supposed to be the most bureaucratic and non-service-minded board in the country, but is now one of the most effective and service-minded board due to heavy use of internet and the website. I need to change the slides. Thank you. So, this is also true of Sweden's healthcare sector. Close to 100% of patient records are digitized, and the percentage of pharmaceutical prescriptions that are made through our national digital system is almost as high, and that has been since quite a long time. The number of digital services in healthcare has increased, and also the number of people using them. For example, since 2014, we have seen an increase from 1 million citizen accounts at the National Portal for Digital Services 1177 healthcare guide to almost 4 million accounts. And we are about 9 million people in our country. Moreover, Sweden has national quality registers that contain vast amounts of data on patient outcomes, a gold mine for research and development. The digitalization of the healthcare sectors has helped us in many ways, and one example is life science. Sweden offers a thriving life science environment, which is technology-driven and characterized by close collaboration between academia, healthcare, and industry. Our healthcare system, to which all citizens have access, along with the personal identification numbers introduced in 1947, has generated unique, comprehensive patient registers and made functional biobanks possible. Life science is a dominating line of business and a cornerstone of the Swedish economy. Supporting research, innovation, and co-creation in the life science sector has been a long-standing priority for the Swedish government. And the climate for research and development is positive across a wide range of sectors and stakeholders. And in 2015, overall Swedish investments in research and development totaled 3.3% of our GDP. So we have also had an active digital policy for a long time, and we have set up 3 main targets for this policy. Broadband is of great importance for us. Sweden has a lot of sparsely populated areas, especially in the northern part of the country. And we need to make sure that as many citizens as possible can have access to internet to create opportunities for living and working, as well as inspiring growth and innovative production. But of course, a well-functioning broadband is a prerequisite for different e-health services. We often say that the broadband is the cake on which one can add many layers of icing, for example, telecommunication with doctors. So this is the positive side. But on the other hand, however, we can see that the Swedish healthcare sector does not fully utilize the opportunities offered by digitization. We still have problems when it comes to, for example, system interoperability and non-user-friendly systems. Perhaps one of the most fitting examples is that despite our high degree of using internet and various applications, the fax machine is still a common tool in our hospitals and health clinics. Patient records are printed, faxed, and re-digitized for both technical and legal reasons. And the reason behind this problem may not be that we still live in a world where we believe that healthcare is given the old-fashioned way. The patient contacts the healthcare provider via telephone. They get a visit at a doctor who is stationed at a hospital or primary healthcare center. An intervention takes place and the patient gets well. However, as the commissioner mentioned a few times, we have a changing disease panorama with more patients with chronic diseases that visit many different caregivers during their lifetime. And different digital solutions give us plenty of opportunities to meet the patients the way that best suits them. And if we are going to handle the demographic growth, now we also need to use these new tools. So what should be added here is that there is no one-size-fits-all when it comes to patients. In the best of words, there should be the opportunity to communicate with the help of e-health solutions, but also opportunities to meet at a district nurse in place, for instance. What we are doing now at the national level to get even better, what are we doing now at the national level to get even better in Sweden? Well, last year we decided upon a vision for Sweden's health policy. I think we have some competition here between our countries. The vision is that by 2025, we aim to be the best country in the world at using the opportunities offered by digitization and e-health in both health and welfare. This is a vision for both the healthcare system and social services, jointly decided on by the Swedish Cabinet and the Swedish Association of Local Authorities and Regions. And the two most significant aspects of e-health in the healthcare system in Swedish e-health policy are the following. For patients, to be able to interact with healthcare system and take part in their own care. For professional healthcare workers to have access to good clinical decision support systems and efficient systems for accessing and recording patient information. And the vision includes different important principles. One example is equality, which is a fundamental aspect for the Swedish government. People who live under different socio-economic circumstances should have equal access to support according to their needs and to be treated on the basis of their own personal position. And by making tools available that support actions tailored to the users, clients, and patients' individual needs, digitization can make it easier for the services to work for increased equality. It also improves possibilities for follow-up and analysis of unjustified differences between outcomes in different services. Another fundamental principles are accessibility, usability, and digital participation, as well as protection of privacy and information security. As far as possible, digital services are to be designed for universal use in accordance with the Design for All concept, which means that IT support should be available to and usable by all people, irrespective of age, disability, level of knowledge, and other conditions, without any need for adaptation or special design. We also see that digital solutions can be used in rural areas. For example, Västerbotten County Council, which is located in the northern part of Sweden, has focused telemedicine to improve accessibility to rural communities to healthcare. Physical services are concentrated in a small number of 2 primary healthcare centers, and telemedicine is utilized to deliver service to more remote communities. Since the mid-1990s, close to 40 different health applications and 230 video conference facilities have been rolled out across the county. So more people now have much closer to the doctor than before. And they don't even have to, sometimes even don't have to leave their home, or at least not their village. So we do not only work together with the county councils from the Swedish government, we also have ways to cooperate with other actors, such as professional associations, entrepreneurs, and organizations representing patients, of course, user and family organizations, the industry, and many others. One thing we learned in Sweden is that the best results are achieved when we work together. And this is true, of course, both at national and international levels. Therefore, we welcome the work done by the Estonian and the presidency on e-health so far. The first Council conclusions on e-health were agreed upon during the Swedish presidency in 2009. And I'm very glad that Estonia is now working on new Council conclusions on this issue. And I also understood that a Digital Health Society Declaration has just been presented here during the conference, and also that the process behind this declaration has been developed collectively within the EU key stakeholders, which is another good example of cooperation. So, to sum up, e-health can make it easier for the healthcare sector to work for increased equality. To get there, we have to make sure that the digital tools are tailored to the users, clients, and patients' individual needs. We look forward to continuous cooperation on the EU level to both share our knowledge and, of course, to learn best practice from our fellow EU countries. And we know that the best results are achieved when we work together. Thank you.
Tack så mycket, Agneta. And this is very interesting to be sharing and healthcaring the experience of the different states and countries in order not to do the same work twice. And I think you mentioned the applications Skype, and I think there was an Estonian hand in it as well. I'm from Finland, I don't really give a damn as long as it works. But let's go to the next speaker, Mr. Clemens Auer from Austria. Let's hear the Austrian experience, please.
Thank you, Minister, Commissioner, for the nice invitation, putting digitalization in health so prominent on the topic of your presidency. For me personally, to be honest, digitalization was never a threat. It needs a positive connotation, especially in the healthcare sector. And it's not a negative disruption. I think for us in the healthcare sector, and I'm not a technical people and a person, I'm not a technician, I'm not even a medical doctor, I'm a boring bureaucrat. But for me, digitalization is always one of the most important instruments to drive the quality of the services, of healthcare services. That's what it is about. I have two hats today here. One, yes, I'm a Director General of the Ministry of Health in Austria, but I'm also the co-chair of the EHEalth network, the network of the competent authorities in the European Union working together. And I personally have probably a very dusty apron because, yes, I am plowing the field of implementation of digital services for many, many, many years now to make things happen. And it is a very, very long and hard work, and you get very dusty doing this. But let me talk about the role of the EHEalth network on the European collaboration and where are the successes there, and where are probably also the shortcomings in that collaboration. Let me emphasize, and I was listening very carefully to all these wonderful digital initiatives also this morning. For us, the government, so to say, for us, the boring people, the only format we have to collaborate on a strategic and political level, next to the Council, of course, is the EHEalth network. The EHEalth network has a legal base in Article 14 of the Cross-Border Directive of 2011. And it is the working place, so to say, the format where the governments or the competent authorities who are responsible for implementing EHEalth are collaborating. And the mandate is very broad. It's not only about e-prescription and patient summary. Yes, this language is also mentioned in Article 14, but it's a broader mandate because the EHEalth network is meant to deliver toward sustainable and economic and social benefits in the healthcare system and health services, number one. Number two, interoperable applications, to deliver for interoperable application, to build trust and security among member states, and to safeguard the quality of care. So the mandate is broad, and we are working within the frameworks of multi-annual work plans. We are just working on the next one for the years 2018 to 2020. And to be frank and honest, since I am a Director General for quite many years now, as long as we member states don't have these strict and organized formats to collaboration, we don't make progress. Because we're making progress on some kind of progress on the EHEalth collaboration. We have a second very similar EHEalth network, so that's if it comes to the rare diseases and the reference networks, we are making good progress there in collaboration. As EHEalth is not the only topic I have, I wish we would have similar mechanisms to collaborate if it comes to access to medicines. We don't, so we don't make progress on that topic. So what are the successes so far? Yes, the EHEalth network was able to pass us guidelines on patient summary and on e-prescription and how to set up patient registries. Yes, we were able to agree on a European interoperability framework. Yes, I think the EHEalth network has a key role in the implementation of the EHEalth digital services infrastructure the Commissioner was referring to within the framework of CEF, the Connecting European Facilities. Because I think it was necessary and it was very, very good that the member states had this format, the EHEalth network, to set up the necessary organizational framework, to build on the trust we were able to build up over the many, many years. And, ladies and gentlemen, the progress is that we are capable of of implementing infrastructure, the so-called national contact points for e-health, which are the gateways between member states to exchange health data. I think this is not nothing. So we can't say that there is no progress, because this is pretty big progress. So in the spring 18, the first member states will have this infrastructure in place and will be able to exchange patient data. It's about patient data cross-border. And there's also, as the Commissioner mentioned, 16 other members, altogether 16 member states by 2020 will be capable of using this infrastructure to do so. So, ladies and gentlemen, there is progress. Where should we make maybe more progress? See, and as a member state representative, I can say that, the Commissioner can't. You know, the member states, we always use the grand rhetoric of voluntary and non-binding collaboration and cooperation. This is our grand rhetoric. To be honest, sometimes I can't listen to it anymore, because it is weakening the political will. It is weakening the political will. I think we should talk less about voluntary collaboration. We should talk more about commitments, committed collaboration. But that's how it is, you know, because we all love to be by our own, and we don't want the Commission to tell us anything, because everything is voluntary and non-binding. So, but what does it lead to? It leads to that certain, the Commissioner, but what that leads to, this lack of commitment, that we're still lacking behind in certain prerequisites for the exchanging of data across borders. Ladies and gentlemen, we have to be honest. Do we really have in all 20, how many? 25, I think, I'm saying, that's 26, member states up and running mechanisms to identify, electronically identify patients? No. There is a handful of member states who are capable of doing so. Do we have up and running electronic identification systems for healthcare providers? No. That's a handful, maybe 2 handfuls of countries who can do that. Many other member states still do identify healthcare providers on paper, which is not very useful in a digital time, you know. Do we make progress if we talk about interoperability in terms of semantic? Have we agreed on the modern or the right ontologies? Once again, I'm not a technician. I'm not a medical doctor. I cannot even tell you what the right semantic ontology is. But we have to agree on a ontology. Otherwise, we don't have semantic operability. We're making very little progress on formats, technical formats and standards. Yes, we don't make enough progress there. So my plea is, so to say, to soften down the grand rhetoric of voluntary and non-binding and strengthen the rhetoric of certain levels of commitment. Where do we have to improve? And I think we have to improve in identifying and overcoming the implementation challenges. Because this is not only a discussion we have to have on the European level, among us EU member states, it's also a national thing, you know, because there are barriers in exchanging data. There are huge barriers. Patient data, the data for secondary use, big data, so to say, you know, call it whatever. My observation is that there is not a lack of political willingness to do so. This is not my biggest concern, that on the political level there is no willingness. I think there is willingness, so to say. But we have to identify all those restrictions of our current digital infrastructure in the healthcare system. I think our digital infrastructure we have, some member states have the privilege to have pretty new infrastructure. My country, Sweden, many others have pretty old digital infrastructure. So we have to come to realize that this up and running digital infrastructure, which is working in hospitals, or think about the digital infrastructure in the outpatient sector, I don't want to even start talking about it, is not equipped, actually, is not equipped to do what we want them politically to do, to exchange data. Patient data or big data, anonymized data for secondary use, etc., etc. So I would also call not only on to us, boring civil servants and politicians, to improve our act. Where is the industry moving there in that field? To have up and running modern and new generation of infrastructure which is capable of exchanging data. A hospital information system, and I think we in Austria have fine hospital information with the best vendors. Hospital information systems were made to optimize the internal processes within a hospital, but not necessarily to exchange data with third parties. And that's a problem, because each and every thing we put on top of this hospital information system to exchange data with third parties creates a fuss, is complicated, etc., etc. So I also call the operators of hospitals, the managers of IT infrastructure to be more bold and be more clever in overcoming these hurdles. But for us in the public sector, we have also to realize that we do need incentives to do so. And we do need public investment in this new generation of digital infrastructure in the healthcare sector. If you ask me personally, what is the next big topic we have to do politically, then it is exactly that, to secure the public investment in this new generation of digital infrastructure. Because once again, and the practitioners in the room do know that very, very well. Look at the quality of digital data in the healthcare sector. It's a shame. It's a shame. This quality of data is not made to be exchanged. Be honest. Be honest. This is not what we need. So we do need investment in that sector, because it's also about the quality of data. And once again, why are we doing this? I am not a technician. I'm not a medical doctor. I am a Director General of a Ministry of Health. My prime responsibility, the prime responsibility of the Secretary of State or the General Secretary of the Dutch Ministry, our prime responsibility is not digitalization. Our prime responsibility is the quality of healthcare services, the continuity of healthcare services. And for us, this is a tool, ICT, so to say, and it has to go in that direction. So my last message here in this room is we have to think more bolder. We have to think anew. We have to use the enormous infrastructure funds we have on the European level to invest in this new digital infrastructure in health. It's not only about bridges and highways or building new hospitals, grand hospitals somewhere in the landscape, because hospitals is not our main problem in the healthcare sector, or the lack of hospitals. So we do need these investments in digital infrastructure, and we have to set up the mechanisms to do so. We have to secure the funds, but we also have to agree what we need, for what, and how can we implement. I have two wishes to close here. My first wish is to the Estonian presidency. I think Minister, you're doing a wonderful job in driving this agenda. But I also would like to ask you to be more bold in formalizing the council conclusion, which we hopefully will be able to pass in December, early December in the council. If you want to leave a legacy in digitalization and health, we have to put some language in which is really pointing to the future. It's a wonderful first draft, but it has to be improved. The Swedish Council conclusion is still the basis we are working on in many, many respects. So be the second one to do this. This was my first wish. And my second wish is to each and everyone in this room. If you have the slightest suspicion that some politician nationally or on the European level, might want to abolish the health dossier on the European level within the Commission or somewhere else, please raise your voice, protest that, because health has to be a European topic in every respect. Thank you very much.
Thank you very much, Mr. Auer, for this honest look in the mirror that we all need. And I think this raised many questions in the audience. And before we start this Q&A, I would like to invite to the stage our Minister of Health and Labor, Estonian Minister of Health and Labor, Mr. Yevgeny Ossinovsky. He presented his views yesterday, but I use my position as a moderator to ask the first question. So how would you respond to Mr. Auer's slogan that Estonia has to be more bold in its actions on the health field before the presidency ends in December? We have 2 more months.
We'll try our best. We spoke with Clemens earlier there about the same thing, that of course we will try to be as bold as possible to get everybody on board, but at the same time to show some guidance towards the future on this important topic, because in the end, I think understandably, the countries are different, the systems are different, histories are different, but I think we have got to a point where instead of looking for excuses why not to do things, we are finally talking about real things that need to be solved in order to move forward. And our discussion at the informal EBSCO in July, right in this room, I think, was extremely positive, I have to say. The general political consensus was that we really need to move forward with that, and I think it's a good basis for both having ambitious council conclusions, but also to actually start moving forward.
But as Mr. Auer noted, on the European level, on the government level, there is lots of goodwill, but let's go to the grassroots level. That's what the problems lie. Do you agree?
It's just, it's not just a matter of lack of will, but it's actually a complex issue that actually has to be solved from very different aspects. And of course, there has been some gaps in here, be it interoperability, be it privacy regulations, but we're slowly filling those gaps in terms of privacy regulations on the EU level and so on. So I think we're moving in the right direction. Are we moving fast enough? My personal opinion is no, of course not. We should be much more ambitious and much quicker in that.
Good. Okay, dear people, you must have some questions. Hands being raised. None. My God. There's one.
Yeah.
Good. Please, wait for the microphone.
So where's the hand?
Please stand up.
Okay, there.
I'm like Bob Marley. Get up, stand up. I'm creating a movement here. Please.
Very close. Okay. Thank you. My name is James Kennedy. I work for an association called the Aboriginal Alliance, which is a group that represents industries and researchers doing predictive medicine. Our Austrian Director General had a very positive thing to say, is that we need to identify gaps or restrictions in policy and also to get industry to move. So I'd like to give it an example of a problem today. If you look at computer modeling and simulation today in healthcare, there's a lot of industries that are in engineering and aeronautics and things like this that are transitioning to healthcare. So they're saying, if we can model fuel injection systems for Formula 1 cars, maybe we can model blood flow. Today, however, in healthcare, if I could develop the most advanced predictive model in the world that shows how fantastic my medical device is, how it's much more safe and lasting and things like this, that model is completely useless if there's no regulatory system where I can submit that data and be able to show that. So in marketing authorization, in health technology assessment, there's simply no framework by which you can submit that data to show that your device is safer or better. The same as in drugs. So there's been a lot of focus on the rollout of care. I just wanted to look at the product development side. So my question would be, should we wait for the US to roll out this policy framework where there's already investments, or should we get to work right now?
So who the question is addressed, or in general, for all? Who wants to respond?
Who's brave enough?
I agree with you fully. We need to move in such direction. But, as you know, at EU level, to build a framework of regulatory framework is not so easy task, because, first of all, we need to encourage two legislators, yes? Okay, Commission is ready to propose a lot of things. Health technology assessment proposes on pipeline. Okay, we'll see how to do it. But then you have two legislators. One is Council, or 28 member states. Okay, now 28. Tomorrow it will be 27.
You wish.
Okay,
Maybe
27.
28 again.
I agree with you. Okay, but then you see European Parliament. Okay, and also we need to understand when we are debating issues about some regulatory framework, all operators are around us, industries, associations, and so on, so on. It's not only simple way, you know, to say, okay, we just build such framework immediately. But we need to move in such direction, because I agree with you, without instruments, or legal instruments, it will be really a lot of difficulties. But I will ask Clemens to react, because Clemens knows much more, because he is involved in businesses a long time, and he knows very well details. But I think he will agree with me also. We need to have some really better framework of regulation. And speaking about health technology assessment, it's not so easy task, you know. We started from very bold proposals, and today we are going, you know, because we see how many countries are in favor, how against. Some are sending signals now, and we will try, and we will see finally which proposal will be on the table. But believe me, it's a very complicated one issue, like today's topic.
Clemens.
I think, you know, this is our core business, to have regulatory frameworks in place. You know, that's because we, hopefully, we still all believe in the rule of law, and that our populists are not getting out of the, you know, don't, whatever, abolish the rule of law. But as long as the rule of law has to be the first principle, we have to be, we need regulatory frameworks. And, you know, I was working, and, you know, I'm in this business really for quite a while, but my most challenging legal work in Austria at home was the legal work on electronic health data in the digital, as a digitalization of the healthcare sector, because, you know, you shouldn't go too far and to be too restrictive and to stop future developments on the one hand, but on the other side you have to, because it's personal data, you know, health data is personal data, the holy cow. And I think it's also rightly so a holy cow, because it's a human right that personal data is protected. But you have to find the balance. And once again, this was the most challenging piece of legislation I was involved with. Was our electronic, telematic, the framework for health telematics. Yes, so I agree with that. We do need sound legislation or legal frameworks. I am not in the business of blaming the data protection agencies very, very quickly. They are doing their job. I do know that they are a pain, because I am working with them all the time, and the Austrians are, you know, and if you go there to these committees, Jesus, I don't know where these people sometimes live. But if you have a strong case, and if you are capable of also showing that you are protecting the interest of the citizens simultaneously, then they can't say no. But this is hard work. You have to do it. Just to complain is not enough. You know, you have to convince them. So yes, I'm with you. We do need strong regulatory frameworks on the national level, on the European level, and data protection is not the most. Is not a barrier. You know, we have to work with them, and otherwise we can't make any progress.
Yes.
If I may, you know, we all must agree on a very simple issue. As you heard from Commission side, European Commission must be big on big and small on small.
Yes.
Okay, health is big or small?
Big.
And small.
Big or small?
Both.
I do not hear your voices. Because if small, that's okay, it's closed. But it is big, then we have good opportunity to move in such direction. Because it's not only mantra about voluntary, it's always mantra about subsidiarity. It's very important mantra, friends. And this creates a lot of problems. Okay, it's in the hands of member states, sorry, once again, sorry. And then, can you imagine how long was way of introducing cross-border health patients' rights directive? It takes 10 years. 10 years. And yet I personally see that we are in big delay speaking about possibilities to build a digital infrastructure around you. We are thinking about digital single market, yes. Okay, what will healthcare issues are included in this digital single market or not? My answer, yes, they are included here. And we need to move forward because, you know, our obligations till 2020 and in 2025 will be far from implementation. And I ask you to be very vocal, all operators, and to send messages to parliaments, to governments, to European Parliament. Commission is ready to move in such direction, but we need to join our forces speaking about health as big issue at EU agenda.
But do you think that the environment or the technology or the means is already here, that we could really move forward? If there's a will, there's a way. Do you agree that, Evgeny, Agneta? Do you think that it's already here?
Well, I think we can do a lot of cooperation and exchange examples and so on. And I think health is really important to be on the EU agenda. But at the same time, I mean, in our parliament and in our country, there are no willingness to give over more responsibility to the European level. That's a fact. I mean, we can have a lot of ambitions and wishes, but we do need to listen to our citizens. And there are a lot of skepticisms to go further on in harmonizing our welfare systems and healthcare systems. So that's why we have to be a little bit cautious and give and take and listen and exchange views. But of course I think we can do more on that side. But then when it comes to integrity versus patient safety, I mean, that's a very tricky issue. We have exactly the same discussion in Sweden as in Austria about our national agency that is looking into how we are following the integrity of the citizens. And they have a strong mandate. They probably have even a stronger mandate now after the patient directive here. So I mean, that's a fact. And in Sweden, it's also written into our constitution. So we cannot just, you know, try to go around it. I mean, we have to deal with it. But as you said, if we have take time to really explain how patient safety can, personal integrity can be taken care of, if we do that analysis well, we can do changes. If we get the approval from the patient or their relatives, then we can change data and do a lot of things. But we have to be serious about that balance. And sometimes it's easy to joke about it, but it's a real fact, and it's a problem that we cannot just try to not see. We have to deal with it together. And I think we have the same challenges there, really.
But it's interesting, in this discussion, we are in kind of a cross-section of public policy, public interest, and the business. And when we talk about healthcare, we don't want to use the word business. As somebody mentioned in the earlier panel, it seems kind of dirty that somebody makes profit on our health. So how you bring those two groups together? The businesses see the regulators usually as obstacles, but we have to work together because healthcare is one of the fastest growing businesses in the world.
What I think is old stereotype, nothing new. Business also blame regulators. It's for all my life, that's absolutely. Why? I don't know why. But if you look at a situation to have proper regulation, it helps a lot to develop business.
Yes.
Why we are using always such confrontation? I have no sense. From my point of view, it's mantra which is always used. Of course, we know very well that some regulatory frameworks are old, obsolete. We need to change, to move into REFIT. The Commission is do our homework. We are on REFIT. We have on REFIT a lot of regulatory frameworks and to see how to, because all things are in changes, of course, no doubt. But we need to understand each other. We need to have proper regulatory framework, which helps business to develop their capacities. And of course, also patient safety. Who will be against to have proper regulatory framework on patient safety? No one. Okay, we need to discuss those issues. Of course, quality of services, who will be against? Now, control of quality of services, who will be against? Okay, I think only one way to cooperate, private-public partnership. Good 3P. I like very much 3P. Prevention, promotion, protection. 3P in my life, because it is up to all of us to understand. It is so important for me to see such 3Ps in very, but fourth P is participation. Private-public partnership and participation, the same.
Okay, Clemens, what are your favorite alphabets?
No, it's the innovation, so to say. I think there are several sectors, industry sectors or whatever sectors driving the innovation in the healthcare sector. That's, of course, pharma is one, and the digital sector is the other one. But, to be frank and honest, not everything which comes as an innovation or pretends to be an innovation must be an innovation. And that's very much true in the pharma sector. And we know how little true innovation in the pharma sector is. Most times it's not. I think there's more innovation actually in the digital sector. But still, not everything which pretends to be an innovation has to be an innovation. Okay. So the question is the assessment. Because we have to make implementation decisions. See, Agneta, me, Eric, we all have to make that's our daily business, so to say, if we are responsible on the national level, but sometimes not, but sometimes we are. We have to make this implementation decision, and therefore we need fair assessment. So all these wonderful startups which are coming to my office, having a wonderful innovative idea, they have to be they realize that they have to be assessed, because we have to assess the innovation. Having said this, not every assessment which pretends to be an assessment is an assessment too, so to be frank and open. Yeah. Therefore, we need regulation on assessment. Yeah. So, it's a check, it's a balance. So, it should be clear that I am on the side of innovation, so because tomorrow I want to sit on the blue chair, Minister, and not on the red chair. But this has to be a balance, and innovation needs assessment. That's one of the key messages I also would like to say.
But Mr. Osinovsky, I'm sure in Estonia you have lots of those startups coming to your offices, presenting their new ideas. They present here the new ideas for us also. How you assess them? The government is very favorable for all new ideas and new kind of implementations in IT sector, but where is this burden of proof?
Yeah, first of all, I think this business interest in healthcare or in the context of public health, I think it is a sort of controversial one, precisely for the reasons you said. And in some spheres of public policy in healthcare, of course, the interests are legitimately absolutely opposite, like in alcohol policy, for example, which is my other favorite topic apart from e-health. In pharma, it's somewhere in the middle. But with e-health, I think it's a good place where actually there is a convergence of interests in this regard. So there is no opposition. But if we talk about how to link together technological developments and public policy on the other hand, and healthcare systems, then I think there are two fundamentals here that have to be in place. Firstly, it's the data protection framework that has to be solid enough. And here I go back to what I said yesterday, that one of the biggest cornerstones of successful e-health systems is public trust. And public trust comes from the belief of people that nothing will be done with their data that is either contrary to their interests or that is, or I would even be more extreme, that is not favorable to them. And that's the
but public trust in who? In government that controls this, or in companies that are honest using this data?
Yeah, well, now I'm talking about government-owned or patient-owned, but government-controlled information being used for research and development, technological innovation, and so on. Of course, people are free to share their data with companies directly, and many companies do that. And for that, you have to have a data protection framework as well. I'm talking about it's sort of public policy-led process here. And the second is that these innovations would be used for the benefit of those same people. So that you're saying that firstly there is a solid framework that your data will not be misused, but secondly that the innovations that come out of use of your data will be beneficial to you. And that is an important question with startups, for example, that some might do research on Estonian data here and then actually export their product somewhere else so that Estonian patients don't get anything for that. And in this regard, I think that these two things should be put together, and it means trying to plan innovations from beginning with having a clear plan how to actually implement it into your own national health system, in which I don't think we have been very good here in Estonia. So we have the fundamentals in place for that, but we haven't been very good at actually implementing these technological innovations into the system afterwards.
Okay, let's have a public question.
There is one.
Oh, let's have ladies first.
Yeah, okay. There are lots of ladies.
Oh, and then ladies. Second and first.
Thank you. I'm Ruth Amos, and I actually serve on the HIMSS Legal Task Force in the United States. And it's a group of about 18 healthcare IT attorneys who comment and review healthcare IT legislation. And so my question is also to the HIMSS Europe people and the panel, is there something similar in HIMSS Europe that would review proposed legislation coming up before the EU? If so, what are your thoughts regarding the efficiency of that group? And if not, are there plans to begin one? Thank you.
Who will respond?
HIMSS people in the audience.
Sorry, of course it's a very difficult question for me because speaking about a relationship between EU and US, you know, we try to achieve something, big progress, speaking about different areas of regulation in TTIP, you know, but you know today's situation, because TTIP touched a lot of different areas, starting from IT, finishing sanitary, phytosanitary issues. I was responsible more on SPS, on sanitary, phytosanitary files, and of course also on pharmaceuticals, but it's not on IT. But I know that IT were there on the table, how to you know, equalize, how to you know, harmonize, how to see possibilities to have more you know, recognition systems, how to avoid red tape, and so on, so on. Generally, it was about TTIP. It was about, but.
So the but is we don't talk anymore?
Stopped. Sorry, you please ask United States administration, not me.
Okay.
Okay, let's take the next question from the audience.
Yes, hello, hi. My name is Barangelo. I'm actually at the Center for Personalized Medicine at the University of Tübingen in Germany. I think it's actually really quite clear that what we want to do with this data actually is to be able to exploit it at the end. And therefore, what I really want to do is actually emphasize one of the things that the Director General from Austria, Clemens Auer, had mentioned, was that the nature of the data that we're collecting in these institutions is not necessarily, let's say, well-tuned for exchange. And what I really want to actually say, I happen to also be a cardiac surgeon. What I really want to say also is that one of the struggles is actually making sense of the data from the point of view of what does it mean, and how can we use that information for prognostic and predictive decisions that benefit individual patients today. From what I can see is that we really will need to almost reimagine, reorganize the way that clinicians and healthcare providers actually operate, collect that data, store that data in a way that is exploitable in the future, right? Because I can deliver, and we do already today, a lot of useless data. And I was just wondering, for example, in the Austrian experience or anywhere else in Europe, what have we thought of, and is there any thought to sort of re-engineer that collection process, making sure that it is useful before we start sending it over the wire, somewhere where we will tell them that they must be able to use it. I think we really need to make sure that the cart stays behind the horse at the moment, because if we turn it around right now, there'll be a lot of people unhappy in 25 years.
Thank you.
Thank you.
Start from Austria again.
I think the question of quality of data should really be one of a big concern. If you talk about a simple patient record or a health record, so to say, a simple thing. I don't talk about a very complex clinical study protocol or whatever. Even the simple things, the quality is not there.
So how you define quality?
The volume of information sometimes in this and how it is composed, and it's many times it's not coded, etc., etc. Medical doctors don't like coding, for some odd reasons, but otherwise, if you want to have a standardized exchange of data, then you need some coding. I think the pressure on this is a little bit softened, because with these new algorithms which are now developed, in terms of also being able to analyze unstructured texts or whatever, it's probably softening the burden and we will probably be up in the next generation of pretty good quality of data. But we have to work on that. Right now, I think the quality of data is not very good. Since you are a very nice medical doctor, I don't think that you want to have a secretive language, because you're not saying that. But yes, we have to think about, how to collect data and how to protect data, to collect it, and what kind of data. This is what we really have to look into. And excuse me, I am the ugly bureaucrat here. I cannot tell you how to structure your data in the medical science. You can have a good plan, and then I might come up with a good regulatory frame, hopefully. But I think you in the medical field, and I don't want to play now ping pong with you, but you know what I mean. You in the medical field and science or whatever, I hope that medicine is a science, you have to you have to structure that, and you have to have this kind of discussions. Yes, I'm with you, and in the end we might need a sound regulation with that, yes. But no, nothing more to say.
Mm-hmm. Okay, let's have one last question.
Thank you very much for a previous discussion. My name is Melita Sogomonyan. I'm from Tallinn University of Technology. So my question is very simple. Is there perspective to include health policy into the competence of EU, which means amendments in the include health policy into the competence of EU? So that means to make amendments in the Treaty of the Functioning of European Union, basically in the Article 5 and 168 about public health. So the question is, if yes, when? If not, why? The answer may be is not accepted. Thank you.
Okay. Looking
Quick
at Commissioner.
round.
Yes.
Sorry for that. From legal point of view, it's crystal clear. Lisbon Treaty is on the table. And the Lisbon Treaty, you see crystal clear wording. Yes, public health is shared responsibility between EU and member states. Especially if you look at food safety, for example, which is food safety is entirely responsibility of my portfolio. But if you look at medical services and the health care situation, it is explicitly in the hands of member states. And of course, then you have legal instrument, so enhanced cooperation, and of course, possibilities to agree that something must be done at EU level. Of course, when member states, European Parliament, Commission agreed that we need to have much more instruments, and we agreed to adopt cross-border Patients' Rights Directive. Yes, today we have pan-European instrument, European reference networks, as I mentioned. Very important area today to move forward. Of course, Clemens knows it's also on a voluntary basis. but I see big appetite to join our forces here. But of course, second issue is cross-border healthcare threats. It's decision. When we are speaking about pandemics and so on, it's okay. Once again, it's a good opportunity to develop our instruments about vaccination and different things. And of course, we need to move forward discussing how to encourage member states to understand that today we are absolutely in different situation in reality because more than 30 million people from different countries are living in different countries today now, and they have the right to be treated. They have the same equal access to treatment. It means we need to discuss how to really adapt our possibilities to be more effective, helping those people to achieve services. But I see constitutional asymmetry in Lisbon Treaty when we are speaking about medical services, health care and cure, and public health issues. Health care and cure, I see big asymmetry, and I have no advices how to change Lisbon Treaty. From my point of view, it's very tricky. But of course, we need to use now our instruments, cross-border healthcare directives, of course, Council conclusions. Very important instrument is Council conclusions on something that means that Commission is obliged to do and to move forward. And I try to repeat Clemens' words about bold Council conclusions, Tallinn Council conclusions, bold, because it helps us to move forward, not without changes, without treaty change.
So to reiterate your point, Mr. Orr, that we have to move from promises to commitments.
Yes.
To take some more concrete steps. But I have good and bad news.
As a member state representative, I don't see that we can change the treaty very soon. But within the treaty, there's lots of room to maneuver in the health. We have just to broaden the interpretation a little bit, and we can improve a lot there. But the treaty itself, I don't see. My biggest concern is that the next president of the Commission, or whoever is influencing that, might abolish health as a dossier in the Commission, and that would be a pain.
Okay, Agneta.
Yes, I do agree. There will be no changes in the treaty, I think, in very soon. And I think for my country's view, I think think the balance is quite okay now, and we can do a lot of cooperation within it. But then we do sometimes have problem when almost all member states agree that we need to have a new alcohol policy strategy, for instance. And we're still waiting. So I mean, sometimes we do agree, but nothing happens anyway. Well, there's some Implementation. Vad säger man?
Assimilation?
Sorry.
Asymmetry.
Asymmetry.
Asymmetry. Thank you.
Digital.
Even here.
Lots of difficult words in our discussion. But let's give the final word to the host countries, Representative Mr. Ossinovski.
No, I completely agree. There is neither political will nor any impetus to change the treaties here. Many countries would clearly have some constitutional worries about that too. But within that, we clearly haven't exhausted all the possibilities that we already have in this regard, and it's a matter of commitment, as Clemens was saying, whether we actually have this commitment to move forward. You were asking earlier whether technology is there. I think that technologically there's immense opportunities that are already there. The problems, most of the problems are within member states, and some of the problems are of the level of coordination between member states. But a lot of countries haven't done their homework really to move forward on a sort of pan-European level with that.
Okay, interesting point. A lot of countries have not done their homework. But I said I have good and bad news. Good news is we have a break coming up. The bad news is this discussion is over. The next discussion will be in 2 panels, in 2 rooms. In this room, engine room, we will discuss one of the main issues that is in our faces, the aging society. And in a steam room, we continue our innovation, showcasing the companies are showing the products available on the market. But now, a little break.
Thank you.
Good afternoon. My name is Steve Lieber. I'm President and CEO Emeritus of HIMSS, and it's my honor to welcome you to this afternoon's session, The Next Fountain of Youth, Rethinking Connected Health for Our Aging Population. Our speaker today, Dr. Joseph Kvader, MD, Vice President, Connected Health, Partners Healthcare, is creating a new model of healthcare delivery, developing innovative strategies to move care from the hospital or doctor's office into the day-to-day lives of patients. He authored a new book, The Internet of Healthy Things, in which he describes how everyday objects will capture and use real-time biometric data to learn more about the impact of lifestyle on chronic disease and wellness, and ultimately change behavior to improve our health. At Partners Connected Health, Joe is leveraging information technology, cell phones, computers, network devices, and remote health monitoring tools to improve care delivery. Partners Connected Health programs are also helping providers and patients better manage chronic conditions, maintain health and wellness, and improve adherence, engagement, and clinical outcomes. Based on the technology platform developed at Partners, a personalized health technology company was launched and later acquired by a leading insurance company to support its program encouraging healthy behavior and wellness education among employee populations. In 2013, Dr. Kvader launched Wellocracy, a leading source of impartial, easy-to-understand information on new personal self-help technologies like activity trackers, wireless devices, and mobile applications to empower people to get and stay healthy. Joe is internationally recognized for his leadership and vision in the field of connected health. He has authored over 100 publications on the subject. His popular Sea Health blog provides his insights and visions for connected health. Dr. Kvader serves as strategic advisor at Qualcomm Life, West Health Institute, PureTech Ventures, and BD Technologies, and is a mentor at Blueprint Health, providing guidance and insight to developing guidance. Dr. Kvader is also a member of the Harvard Innovation Lab and serves as a judge for its President's Challenge for Entrepreneurship. Please join me in welcoming to the stage Dr. Kvader. Joe?
Thanks so much, Steve. Thanks so much, Steve. With an intro like that, I'm actually looking forward to hearing what I have to say. So I've really enjoyed being here for the past 2 days as a token U.S. person. I know there are a few of us here, but there aren't many. And hearing about the passionate knitting together of these various cultures across the EU. And I have to say I'm a bit envious because in the States, even though we have 50 states, we all speak the same language and we can't do seemingly nearly as much as you all are doing here. So I applaud you for that. I'm going to change focus for the next 20 minutes or so and talk to you about a topic that's become a passion of mine over the last year. When we published the Internet of Healthy Things in 2015, the response was quite gratifying, and so the same group of authors, myself and 2 others, decided that we would do something as a follow-up, and it became this idea of technology, health, and aging. And the more I dug into that, the more I really realized how important a topic that is, and that's what I want to share with you this afternoon. The book that came out of that collaboration is called The New Mobile Age, How a Technology Will Optimize the Health Span and Improve the Lifespan, and it's coming out next week at our Connected Health Conference in Boston. So we hope to see you all there and share some thoughts today about the book. So we're not really getting any younger, right? Either individually or as a society. And I know that sounds trite, but when you think about it, it's actually quite profound. Over the last century, we've added 25 years to our lifespan. Think about that. It's now in the US 78.8. My grandfather died when he was 62 in 1949. My father died in 2008. He was 88. And without any catastrophes, I'll live well into my 80s and probably beyond. Now, that's created a new group of individuals. What we haven't really done, either individually in most cases or societally, is think about what are we going to do with that extra 25 years to add value back, to remain happy, to remain productive, and to capture the gift that aging gives us. We tend to think about it in a very different way. So I'd like to suggest that the 21st century should be the century of the health span. Now, health span is that idea that that extra 25 years should be, again, productive, happy, add value. How can we do that? Right now, too often we view aging as a burden as opposed to an opportunity. We really don't have an option on this. It turns out that in 2020, for the first time in history, there will be more people over 65 than under 5. And by 2050, 16% of the world's population will be over 65, double the number under 5. Now, why do I focus on those stats and that trend? It's because whenever we think of giving care, whether it be in the medical environment or as individuals giving care to our loved ones, we always think about it in a one-to-one manner. And I'm telling you that we're going to have to think one-to-many. We're going to have to think about integrating technologies that allow us to extend ourselves as human beings, because we're going to run out of human beings to take care of all the older folks. It's a simple fact, and that's really a very big part of what I want to talk to you about today and what I want you to start thinking about, because the one-to-one models just aren't going to do it for us for very, very long. So we'll go into that in more detail in a few minutes. So I'm going to ask you, is the population over 65 a burden? As I said earlier, we tend to think of it that way. You know, in 1935 in the US, Social Security became a law. And it's interesting that at that time, the life expectancy was 62. So you can imagine these policymakers saying, well, you know, if you make it to 65, we'll give you a modest income for a few years until you die off. And I don't think they had any idea that we'd be living well into our 80s at this point. And then, of course, in the early 60s, we ushered in Medicare as a health plan for our elderly. And it's no wonder that some people see that financially as a burden, particularly people in our government. But I have to say, there's also the concept of ageism that fits in here, and this idea of a burden. You know, a friend of mine, he's 50. He's now part of a company. He's a successful serial entrepreneur, and he's part of a company that is trying to take a service that you and I use that's done in brick and mortar and move it online. And I'm not going to share the name of the company because what I have to say about them isn't that flattering, but it's moving a service online. It's a rather complicated service, and he was into the office a couple of weeks ago demonstrating for us what he's doing, thinking there might be a research partnership. And he made the following comment. He said, this is a really ageist company. I'm the oldest person at 50, and they've all given up on selling anything to people over 50 because they say old people just don't get technology. So, you know, if that's the attitude that we have, that will be the outcome that we get. You know, in contrast, think about this, that people over 50 contribute $7.6 billion to our economy. There are 100 million people in the US over 65 that are spending money on things. And I would say, I think that's no question that is an opportunity, right? It has to be. So we really have to rethink it. The other thing that I would say in response to that ageism story is that people that are older add so much back. They have wisdom, they have experience, mentoring, and all kinds of ways that they can give value back. So the idea that we kind of pat you on the head when you're 65 and send you off to do what? Do nothing? We've got to rethink that entirely. So how will we turn aging from a burden to an opportunity? And that's, again, something we talk about in the book. And I'm going to give you a two-part strategy today to think about. The first part is about how we design for an extended health span. So how do we do that? Well, it turns out, and this is going to be interesting, I think, for the medical people in the audience, because it really was a part of doing the book research that I found most exciting for me. The other half of this is going to be about how we re-engineer care delivery, and that's something that I think about every day. So although we have new thoughts on that, this part about extending the health span to me was very exciting. And it goes something like this. Predictors of healthy longevity are a sense of purpose, social connections, and physical activity. And as I learned more about this, I thank my friend Charlotte Yeh, who is vice president at AARP in the US, and she wrote the foreword to my book. She's been a friend for some time. She educated me on a lot of this, both the research behind it and the concepts themselves. And there's just a lovely simplicity to this idea that if you do these three things, you will live longer. And as soon as I got wind of this, I started asking my patients. I'm a dermatologist, so I tend to see healthier, older patients. A lot of my practice is skin cancer. And for sure, I anecdotally saw these things coming out in my discussions with my patients. So I think anecdotally it's there, and as I say, the research supports it. So let's go over each one individually. The sense of purpose thing is profound. There's a gentleman called Eric Kim at the Harvard School of Public Health who's done enormous research on this. And some of his studies showed that people with a higher purpose in life, it's longitudinally associated with a reduced risk of heart attack, stroke, decreased physical functioning, and disturbances in sleep. Just a higher purpose in life. And purpose is also associated with fewer doctor visits and fewer hospitalizations. So those of us who are interested in this idea of decreasing utilization, maybe we just need to focus on this idea of giving people a sense of purpose. And again, think about how we treat retirees now. We actually do just the opposite. We sort of, again, pat them on the head and go play golf or do something like that. And finally, people who had a sense of purpose in life had more preventative exams, things like mammograms, pap smears, prostate exams, cholesterol tests, and the like. All of this has been proven out. That isn't just me saying these things. This is hardcore research from a respected academician. So I guess it's intuitive at some level, but this is a really important one. It's one we can design upon. Social connections. Now, maybe you'd say that is more intuitive, right? That people who are socially isolated do poorly. As a matter of fact, social isolation is as detrimental to your health as smoking a pack of cigarettes a day. It's really amazing. And these days, we have tools, of course, that can extend connectivity. But when you think about it, the older you get, the harder it is to move around, the harder it is to get out of the house. Well-meaning children take the car keys away. It's a challenge, and we need to be aware that as we do those things, they may be the right things to do, but we need to address this challenge of social connectivity. And then finally, physical activity is, again, one that you might say, oh, that makes sense, because, right, we all know that sitting is the new smoking, and that we should all be more active, and that applies to elderly as well. The thing is, as we get older, it's harder to get up and move around. It's harder to put on those 10,000 steps. Maybe we're a little less likely, and as a society, again, think about the way we do this. We create opportunities for older folks to ride around the airport in golf carts and do all these things that don't require them to move. And I'm not trying to be mean or disrespectful at all, but just to say a little bit of physical activity is not a bad thing, and we should think about designing that into our services. So that's part one. Part two is tackling chronic illness. And this goes back to my concept about one-to-many models. And I want to just drive that point home again. You know, today in healthcare, we're really proud, at least in the US, we can offer you a virtual visit with a doctor. But we do that in complete parallel to your own relationship with your doctor. And it's really just another one-to-one interaction. It's not a one-to-many interaction. We have the tools between wearables and home monitoring and all these things to go one-to-many, but we haven't yet harnessed the business models to do so. And we have to do that because, again, we're going to run out of people to take care of the folks that are older than we are. A paradigm shift, in this case, is really needed. So with that introduction, what role does technology play? This is, after all, a book about technology. It's a conference about technology, and certainly technology does play a role. You can bet on it. And it goes like this. All right, for the sense of purpose, think about all the tools that we now have in our armamentarium to be able to contribute to anything part-time from one's home, whether it be task-associated web apps or joining groups of mentors that you can put your name out and say, I'm available from 4 to 6 p.m. every Thursday and Tuesday, and you have that. You can contribute back. You can contribute back as a business person. You can contribute back as a knowledge expert. All kinds of ways you can do that, and technology allows us to do that in really powerful ways. In terms of social connections, that one's probably obvious to you, but it's interesting that, going back to the stats, the people with the most Facebook friends had many fewer medical conditions than the 10% fewest Facebook friends. So the idea that we can get people out, and every time I go to the airport now and see an older individual FaceTiming or Skyping with grandchildren, it gives me a smile because these tools are becoming mainstream even in that demographic. And in physical activity, you'd be happy to know that 17% of people over 65 are using activity trackers, and only 20% under 65 are. So it's not so foreign. None of these things are quite so foreign. The idea that we can use activity trackers and other tools to monitor our health and encourage people, and of course the mobile apps and the overlay of motivational messaging to help people get active and remind them to be active. That's all coming into reality in a way now that's mainstreaming, so we have an opportunity to exploit that as well. Well, as I said, this one is a little bit harder. Now, on the one hand, the tools are in place. things like home monitoring for chronic illness or hospital at home programs. And we all know now that these things are all connected and we can bring them in. That's the continuous standards are about that. There's an enormous amount of activity in the industry to enable easy use of hub devices or even your mobile device as a hub to allow us to round trip data into a medical environment. And it's happening, but on a very tiny scale. And when it does happen, it's often associated with a workflow that requires a human being to, again, get on a video call with you one-to-one. We're back to one-to-one. We need to manage by exception. One quick example in our own system with heart failure telemonitoring, where the nurses will call you if your data are out of parameter, otherwise they leave you alone. And the patients feel more connected, not less, and the readmissions are less, the total medical expense is less, and mortality is less. And there's no problem with that because there's less human touches. It's a technology that extends human beings. One nurse can monitor 100 individuals as opposed to driving around in the car to see 5 on a given day. That's the kind of program that we need to move forward with as quickly as possible. Now, we talk in the book about some of these technologies, and I don't have time to go over them in great detail because I want to leave time for questions and answers, but these are 3 interesting technologies. On the left is Mebu, which is made by a company called Catalia Health. It's a home robot. The middle one is also a robot by a group called Omni Labs. And on the right is a really interesting toy. Yes, that's right, it's a toy made by Hasbro, which is an adult pet companion that has some artificial intelligence built into it. People are building on top of Amazon's Echo interface. All sorts of individuals are taking these technologies. And the challenge for us isn't that they will exist. None of these are new. The challenge is how we integrate them so they extend our relationships as human beings rather than try to replace them. And so think about the time you got on the phone and you tried to get a person and you just got that menu that you couldn't get through to actually get an individual. That's what we don't want to do. And think about companies like Uber and Lyft where the mobile experience is tightly wound into an experience where you actually receive your service from a human. That's how we do want to design these things. So these are all tools, and we talk about many others in the book, but they're tools that if we don't use them well, people will feel alienated, people will feel annoyed, and they won't work. We have to use them to extend our relationships rather than get in the way of them. That's the challenge that we have there. So that's a brief overview of this book and of this concept, and you can tell I'm really excited about it. I think we really have to get on board. As I said, we're running out of people to take care of our older folks. We don't have the time to fuss with this, and this is a blueprint for how we can do it. If we can use tools like sense of purpose, social connections, physical activity to extend the health span, and use one-to-many care models to re-engineer how we provide care, we'll have a hope of having this 25 years of extra lifespan. And by the way, it's going to only get more. That extra lifespan will become a happy time, a productive time, and a time where older people are seen as adding value back rather than being a burden. I hope you'll all join me in that quest. Thank you very much. And I have a few minutes for questions if anybody has any. Are we going to have the roving mic? Yes, here we go.
I really enjoyed that.
Thank you.
I buried my mother 2 years ago. I've been using technology in social care for 15 years. And when I talked to the people who were delivering her care, they had no financial incentive at all to actually use technology. How do we scale up?
Yeah, it's a great question, and I alluded to that. So I don't mean to imply that it's as simple as having the insight, although there are people out there who still don't have that insight, unlike yourself. In the US, one of the things we're doing, we just were able to add to the code set that doctors can use to bill for services 2 new codes. One of them is for remote monitoring reimbursement. Now, that doesn't mean that that will get paid right away, and doesn't mean it'll get paid by our government payer, but it's a step in the right direction. So that's one way, thank you, to do it, is to try to get mechanisms in place. When we talk to doctors and patients in the US, they tend to see all around the value of this kind of an approach to care. And so I think it's just kind of waiting for a spark, to be honest with you. And we hope that this change in reimbursement will be the spark that fires. Other questions? Yes, sir. I think the mic. Thank you.
Thanks. David Somick from European Health Futures Forum. I'm very interested in your statistic about the use of fitness apps by elderly people. That was an extraordinarily high figure that you quoted. Is this across the social spectrum, or just in it? Because the research I know about from University College London, for example, their behaviour change centre showed from Australia that it was really AB, you know, the higher social levels that were using these things. I mean, is that figure really includes all the disadvantaged folk within that age group?
Well, so the data source is a study done by, I believe it was Accenture about a year ago, and I'd have to go back and look at how they did their polling. So I don't want to say flat-footed that. I believe it was a U.S.-based study, so that may have something to do with it. And I believe it was a broad sample, but again, I want to withhold a little bit of my enthusiasm because I have to go back and look, but that was my understanding at the time. I think I'm between you and lunch, so I'm going to say thank you again and enjoy your rest of your day.
Hello, good day to you all. Did you enjoy your lunch? As you can see, I'm alone here, and I can see that Neme took like half of the public away with him somewhere. Okay, let's continue with this session. I know this is not the best time to continue with serious discussions because it's after lunch and it's like being on the 4th place in the Olympic Games where you just miss out a bit on the medal because everybody's like having their blood circulation in their tummy. But let's try to concentrate because we have very interesting speakers coming up. So we have a panel discussion coming where we exchange experiences between USA and EU. And first I would like to welcome on stage Javier Prats-Monet.
Hello, good afternoon. It's not true that this is not the right time to speak because, you know, there's this big research done in Manhattan about trials and judges. And what came out is that if you are a criminal, at least in the US, in Manhattan in particular, you better be judged after lunch or just after breakfast because when the sugar levels of judges are low, their sentences become far harsher. So since some people consider the commission as some sort of criminal organization, and since you are the judges here, I think this is the right time for me at least to speak. More seriously, I'd like to start with a few words of real gratitude to the Estonian presidency. You know, the secret of successful presidencies, from the point of view of the commission, and at least for somebody who's been in the commission for ages, is those presidencies that take a subject as a priority, in which they are confident enough that they will not be judged negatively, and proud enough that they can take it forward for everybody else. And whatever other achievements the Estonian presidency will manage to obtain by the end of this year, one clear achievement is to bring at least further on the rest of the EU on e-governance and in particular on e-health. And for this, the Commission should be really very grateful. So thank you very much. I would like to, we have discussed a bit with my colleague Khalil from DG Connect, and since we should show that we are in the same institution and talk to each other, I hope you'll find our presentation short and complementary. I'd like to say a few words about context, because we are here, in essence, among converts, people who are completely convinced of the merits of technology and the promise of technology, particularly for health. But let's take a look at where we are on health. This is a simple table that gives you a slightly outdated, I know Estonia has gone even further than you see here. This gives you an idea of this is a composite indicator of the development and take-up and use of e-health in European hospitals. You don't need to see all those countries, but what you certainly see here is a huge degree of diversity. Diversity because of the number of financial resources, financial incentives, because of the levels of interoperability of instruments, because of the regulatory framework, different situations in member states, and therefore different capacity, even different willingness and incentives to take up e-health in hospitals. This indicator measures indeed e-health records, the extent to which telemedicine, telehealth is incorporated, the existence of patients' electronic access to their own health, and so on. So a great diversity of situation among member states. Now, what do Europeans think about e-health? Should they have it? Do they like it? Do they fear it? As you may know, we have an initiative on what we call the digital single market, which includes health. So what should we be doing in health? We have asked European citizens in a public consultation where institutions and people could answer. And here you see the interesting answer. There is a huge percentage of European citizens who think that they should be able to manage their own data. 90% agree either just like that or very strongly agree on that. There's a huge percentage of the population who thinks that it is good to actually share health data. There is more than half of European citizens who feel that they do not have access to e-health service. And there is actually 8 citizens out of 10 also who think that citizen feedback, their own feedback to healthcare providers is essential to improve services. So this gives you a picture that there seems to be a real demand from citizens. It's not just a policy wonk, technocrats illusion that e-health is beneficial. But then, what do people expect? I mean, again, the consultation ended on October 12th, so we don't have the official results yet, but this gives you a sense of concerns, apprehensions, and expectations. People fear, predictably, about privacy and cybersecurity, and what they expect is quality of data and a level of standardization of electronic health records. These are important issues, both for good and bad, and my colleague and friend Khalil will tell you more, particularly on the issue of cybersecurity, where we think certainly the European Commission can help. So this is what people think, this is what they expect. Now let's have a look at what the Commission has proposed. Again, Khalil will tell you more. This is just to say that within the midterm review of the digital single market, as most of you know, I don't need to be long, we have found 3 particular areas of added value where an EU proposal could come. First, on patients' access to their own data. This is a right that citizens already have. In some countries, actually in very few countries, such as Estonia, people can actually exercise that right. It's an effective right. They do have access to their own data. It's certainly not the case in most member states. The second is the capacity to exchange data. And here, I would simply stop for a moment because this is not about gadgets. It's not about infrastructure. Khalil will tell you about that. Infrastructure is essential, but it's a means, not an end. I'll tell you the end. The end is something like the European Reference Network for Rare Diseases. As you know, we have diseases that are not so rare, 8,000 of them in Europe, affecting 30 million patients. Well, because of technology, we have created 24 networks where specialists of different disciplines and about 1,000 medical units, 300 hospitals, can actually share data, diagnostics, treatment. This is so beautiful. This is the Erasmus for health. And this is done with a miserably low financial contribution from the EU, the motivation and goodwill of medical professions, and the push and pull of the Association of Patients of Rare Diseases. So this is just a fantastic example not to forget that what we do for e-health is not about E, it's about health. And actually, the real interesting point about e-health is that the E is not about electronics, it's about equality, as I'll try to say in a few minutes. So second area, access, so interoperability, digital infrastructure for sharing. Last but not least, the feedback. As we said before, the patients expect, people expect, the feedback from patients themselves to healthcare systems. This is easier said than done. We know that now one problem that many practitioners have in countries like Finland or the Netherlands is that patients actually come with a very, very clear idea of what they expect from the doctor. And that maybe is another challenge to look at. So this is for the Commission communication. This will come before the end of the year. Hopefully it will be real simple added value to the EU. But I'd like to say a few words to conclude on what does this all mean and why are we doing this? And I'd like to just draw your attention on the fact that indeed e-health has an extraordinary promise, not about technology, but about equity. And this simple graph gives you a sense of the extraordinary difference that we have between life expectancy and healthy life. This is life expectancy at 65 and healthy life expectancy at 65. The EU average, you can see, slightly higher for men than for women, 22 years versus 18. But again, dramatic differences between member states, never mind within member states. If you take, as many of you know, if you take the London Tube, the Jubilee Line at Westminster, and go eastwards toward the East End, every tube stop, life expectancy diminishes by 1 year. Every tube stop. Which means that we have a real obligation to do more about health, not through just health instruments, but through equity instruments, because the first determinant of poverty, of health, is poverty. And if we're going to use e-health, it has to be also to eliminate that. Similarly, health expenditure as a percentage of GDP, this is to show not so much that countries spend different amounts of money in health, but also that money is not everything. You can have similar levels of expenditure with extremely different results. Take the case of the EU average here. You compare to the US has practically the same level of public investment in the field of healthcare as a percentage of GDP. But then to that figure, you have to add an almost identical figure of private investment. So the US now has about 18% in 2015. 18% of the GDP of the US is spent on healthcare, and the outcomes in terms of, for example, amenable deaths are certainly not twice as good as the EU average. So there is an issue to say e-health costs money. Money is not everything, and the purpose of e-health is not a technological ambition, it is an ambition of having access to healthcare for everybody who needs it, and not just for those who can afford it. Yeah, and then one word about what the EU can do about this. I would like to mention just two instruments, since we have a colleague that has crossed the Atlantic just to speak to us on this, on what is going on in Massachusetts. I'll give you two examples of what the EU can do and is already doing. The first one is the EIT Health. I know this well since I was in the board of the EIT when it was born. The EIT is the European Institute of Innovation and Technology. EIT Health is a consortium of 140 stakeholders from 14 countries that gets together public administrations, education and research institutions, medtech providers, health providers, pharma companies, for what? For innovation. And we have a lot of hopes that the concrete innovation by design that the EIT is providing will be a key factor for added value in the EU on innovation and technology in the field of health. We have colleagues here from the EIT who can tell you more. The other example in the minutes that I don't have already to tell you, the other example is the IMI, the Innovative Medicines Initiative. This is 3.3 billion euro, half of it from the European Commission, half of it from industry, essentially, that is there to provide precisely this, innovation in medicines in areas as critical for the future of, well, not for the future of our countries, not for the future of Europe, for the future of humanity, such as antimicrobial resistance, vaccination, the issues that will be a top priority for the EU for one simple reason, because there is no way that issues like this can be dealt with by just one country, one discipline, one hospital. It has to be dealt together in solidarity, public and private, at the European level also as a contribution to the global agenda for health. And these are my last words. I think that the Estonian presidency, as I said, has given us a lot, has given us a lot of food for thought and a lot of initiative and courage to make sure that we use technology for the benefit of patients. Patients are the beneficiaries of our health systems. We should make sure that we don't forget that they should take up what we propose in terms of innovation. Thank you.
Thank you, Javier. And you can stay on stage, and I do hope these were not your last words as you are also discussing in the panel. So please, Kali Ruhana, you're next.
Good afternoon, everyone, and it's a real pleasure to be here once again with you, for those of you who were yesterday. Here, I just want to say that I agree with all what Xavier said, of course, everything. Perhaps on the Commission as a criminal organization, I have doubts, but on the rest, I totally agree. What I'll try to do is very briefly tell you about two areas of policy where we've been acting recently, and we'll be also coming with proposals in the spring next year that are directly related to the issues that were raised by Xavier and that you've been discussing in the 2 days. First one, security, trust as a precondition for the digital transformation of health and care, as a precondition for our citizens to accept, to share data, and to reassure them that their data will not be spread across, will remain and will safeguard its integrity, etc. And we have high quality data. First, security, trust. Mid-September, we issued an ambitious package on cybersecurity, the Commission that put on the table, that includes 3 areas of actions that are extremely important for the health area and for all our digital systems and product and processes. So one area of action is about reinforcing our operational capacity to be able to respond to cyber attacks, to preserve our digital systems across the Union. That includes, in particular, a reinforcement of our coordination mechanism to face cyber attacks, sharing of information, action in real time between all member states so that we can all together preserve our digital systems. And that includes also a new certification scheme that we have proposed at European level to make sure that we have in Europe the best mechanism to certify and validate the cyber security of our product, processes, and our information management systems. I think as for the health area, it's one of the most important areas for application of this certification schemes. It's a scheme that builds on cooperation that exists already between the member states, but that will ensure that any product certified or any service certified in one member state is recognized all across Europe with the right level of cybersecurity. That's one area of action on our operational capacity. We also acted on or proposed measures to reinforce our industrial and our technology capacity to preserve our digital systems, to protect ourselves from cyber attacks, and to be able to respond to cyber attacks with ambitious programs on innovation, but also on partnership with industry to reinforce our technology industrial capacity. That's also a second area where we proposed. And the third area is the international dimension of cybersecurity and cooperation that we need to have with our trading partners and with our partners all around the world to make sure that we together face that challenge. This is a package put in September, and we hope that we will be able at least to pass the regulatory part that is mainly related to our operational capacity, reinforcement of the role of our cybersecurity agency, and the certification scheme. We hope that this will be decided upon in the next year, so as quickly as possible. This is very urgent. That's on security and trust. You know also that we have in the Union today, I mean, you certainly know it, we have today one of the most advanced data protection regulation that protects the data of our citizens. That also should reassure them that they are in control of this data, and they need to, they will be asked for consent whenever their personal data is exploited, reused, etc. So I do think that we are putting together the right regulatory environment as well as the right investment and mobilization mechanisms to make sure that we can guarantee trust and security in our health data. Second area that is important is that came out from the discussion and from the consultation as well is the interoperability of data and the exploitation, sharing of data. That's an area that where as Xavier mentioned, we will be elaborating on in the communication that comes when it comes to the health data, in particular what needs to be done in this field. But in general, also on data, we've been having set of measures that came with the digital single market since the launch of digital single market 2 years ago. We have announced first what are the lines of actions that we'll be exploring when it comes to flow of data, access to data, sharing of data. And in September, we came with the first regulation on the free flow of data to eliminate exceptions regarding the data localization so that the data can be accessible all across Europe and localized wherever in Europe, which would increase the efficiency of our cloud systems, which would ensure also the flow of data all across the Union. That's a regulation that came in September. We announced also that in the digital single market review that happened in May, that we will be coming in spring next year with a whole package that includes the revision of the public sector information that will be related to health, very important. And it will also, we will also come with whatever needed or whatever we observe that is needed to be done on the access and sharing of data. We're exploring various options there, including guidelines, including clarification of what contract law can give. So that's about sharing and exploiting data, which is important for our second pillar in the future, the pillar on the use of aggregated data, anonymized health data for personalized medicine and for research. We need also to see the rules that govern this exploitation of data, that we make sure they are clear and that they foster innovation, etc. These are the actions that we are working on, that we have already proposed regarding cybersecurity and data. And these are, I would say, the latest development or latest proposal that we put on the table when it comes to digital single market, knowing also that we are progressing, but not as quickly as we want on the 16 proposals that we have put on the table to ensure that digital single market, from copyright to content portability to a new telecommunication code. All these were proposed 2 years ago. We progressed on 3 of them. We had adoption by Council and Parliament. There are 13 still ongoing, and we would hope that the now Member States and the Parliament, we get their act together very quickly and have a decision on these so that we ensure the real implementation of digital single market in Europe. That is extremely important for all our digitization action, for the digital transformation of our economy and society, and for the digital transformation of health and care. These are extremely important. Xavier mentioned also the work that we're doing on the infrastructure, in addition to the new regulation on connectivity and an ambitious goal for connectivity, what we call the gigabit society by 2025. We have also put on the table a strategy for building up our data and high-performance computing infrastructure that, as I mentioned yesterday, will be extremely important for the health sector, with first applications of this investment that we're doing together with the member states in this area. First application areas in the health area. This is a €1 billion investment that the Commission has proposed for the period until from 2016 to 2020, and with a matching fund that would come from the member states and a doubling of that would come from industry to build up in Europe high-performance computing infrastructure that is world-class, reaching what we call the exascale computing by 2022-23, and the whole data infrastructure that goes with it that enables simulation, data analytics, visualization with the latest technology, and technology will enable us to act in real time, to react in real time when we have crises, when we have difficult health situations that we can do. So that's what we're doing on the infrastructure side, connectivity, but also computing and data infrastructure with investments that are planned in the next 2 or 3 years, on which we have already started to work together with the member states, and we will be coming by the end of the year with a new structure that will enable us to co-invest in these infrastructures. This is what I wanted to say from our side, and I hope complements what Xavier mentioned. Stay tuned. By the end of the year, we will have a whole communication on digital transformation, health and care, where we put all these actions together. Thank you very much.
Thank you. Thank you, Khalil. And please be seated right next to Xavier. And because sharing experiences is very important, now we have our American guests. Welcome on stage, the director of eHealth, Massachusetts eHealth Institute, Lawrence Stantz.
Thank you, and thank you all for coming today. This is an exciting opportunity to come to Tallinn. I've never been to the Baltic before, so it took a while to get here from Boston, but I'm excited to be here, and thank you very much for inviting me. I always love to hear about what's going on in the European Union. I was particularly excited to come to Estonia because I've heard for years from Brian O'Connor and others about the power and the infrastructure that the Estonians have built here to collect electronic health data, to share it amongst the team. I've seen some of the e-ambulance service in the expo, and it's very impressive. And so I'd love to say thank you for inviting me. I'm going to spend a few minutes talking about Massachusetts and the digital health initiative that I lead there on behalf of Governor Baker and our legislature. So a little bit about Massachusetts for folks who may not know. It is about 6.5 million residents in Massachusetts. We lead the United States in terms of health coverage, health insurance coverage. We were the first state in the country to require that all citizens, residents of Massachusetts have health insurance coverage, which I know is, Europe has been doing this for years and providing it, but in Massachusetts, we were the first in the United States. We also have a tremendous innovation ecosystem and infrastructure, particularly that all leads into what we call digital health or e-health. We have world-leading life sciences, hospitals in Massachusetts like Mass General, Brigham and Women's, Boston Children's Hospital, Dana-Farber Cancer Institute, Joslin Diabetes Center. Many of these institutions are world-renowned and are supporting folks all across the globe through telemedicine and so on. We also, to echo the point about cybersecurity and about the importance of data infrastructure, one of the key pillars of the Massachusetts ecosystem is our cybersecurity infrastructure, and it is particularly applicable in the case of digital health and e-health. So just the obligatory, they sort of imprint these, Massachusetts innovation state, and part of the message I want to deliver is that Massachusetts is an ideal entry point to the United States, particularly for European companies who are trying to come to the US. There are in Massachusetts more digital health companies headquartered there, more large digital health companies headquartered there than any place else in the US, and there are more than 350 total companies, including many startups who are trying out their ideas based on the core infrastructure that we've got. The agency that I lead is the Massachusetts eHealth Institute. We're part of a larger economic development agency, but we were created in 2008 and specifically charged with supporting the adoption of digital health technology, and starting with electronic health records and going towards health information exchange, sharing of that information. And now our primary mission is around building innovation on top of that infrastructure and supporting those digital health companies. So I'm going to talk a little bit about sort of where we've been and then the ways that we're supporting that digital health infrastructure through a program that we call the marketplace. So we think of this as the journey, you know, and we didn't just start in 2008. It turns out that Massachusetts had some of the very earliest electronic health records were built way back when at Mass General Hospital on a language that they invented for the purpose of building electronic health records called MUMPS. And so that was in the early 70s. It slowly evolved from there to the point that today all of the hospitals in Massachusetts have electronic health records and are using it. About 95% of the physicians, about 90% of the skilled nursing and post-acute rehab facilities, and about 70% of the community behavioral health organizations. And my institute was created to make sure that everybody, all health data, all health visits were captured in an electronic health record so that they could be shared. Because that's the only time we get to the promise of digital health, is if not only are we capturing information at the hospital level, but when you're out and getting care in the community, when you're out and getting care all over the Commonwealth. As Javier pointed out, the United States spends twice as much per capita, at least on healthcare delivery as the EU or as virtually any place else in the world. And what we hope we get out of that, because it's obviously not extended life expectancy or quality, but we hope we get a lot of innovation out of that. And so we're trying to leverage the digitized health data and then the sharing of health data to get to driving innovation on top of that. So I'll talk a little bit about the Massachusetts Digital Health Initiative. Starting 2 years ago, Governor Baker charged a group of about 35 health leaders in the state with helping him develop and deliver a strategy for the growth of this cluster and the leveraging of this cluster of companies to improve the health and quality and cost outcomes for the state of Massachusetts. I'm happy to at least, we've made some progress. I used to talk about Massachusetts as the most expensive place in the United States to get health care. We spent the most on per capita. And since the US is the most expensive, we were #1 in the world at healthcare cost. It was great. But we've been working at this for a little bit now, and I think we're now #3 in the US and probably #3 in the world in terms of healthcare costs. So we have a long way to go to avoid bankrupting ourselves, but this is part of the promise. I would just say that, and I don't know the exact stats in the EU, but since 2001, all public investment, basically, net new public investment has gone into healthcare. We have not spent, we're basically in real dollar terms flat on investment in roads, schools, public safety, infrastructure. All of the Massachusetts investment has gone into, public investment has gone into healthcare, and that's something that can't continue if we're to remain competitive on a global basis as we aspire to do. So, Governor created the Digital Health Initiative. Its goal is to make Massachusetts the best place in the world to start and grow a digital health company, and in turn drive healthcare outcomes based on that infrastructure. So how are we going to do that? We're calling this, what we're doing, the marketplace, the Mass Digital Health Marketplace. One of the things we find in the United States, particularly in the area of healthcare, is that there are significant challenges to starting companies, to getting them off the ground, particularly with entrepreneurs who are new to the healthcare industry. And then there are significant challenges on the customer side in terms of accessing new and innovative technologies and solutions. I won't read these off to you, but I think it's important to note that in healthcare and digital health, I would classify sort of the entrepreneur challenges as having two sort of root causes. One is customers are very difficult and very expensive to acquire for entrepreneurs. And the second area of key challenge for entrepreneurs is that healthcare data is traditionally very, very expensive and difficult to integrate with. There are lots of different standards, and many tech entrepreneurs have trouble doing that integration work. So, that's on the entrepreneur side. The customer side challenges have to do with the fact that we're dealing with human lives here. We are innovative solutions have to be tested to a level that is not the same as in consumer tech or consumer electronics or any of the other sort of faster growing tech sectors. And many of the folks flooding into this sector do not have the experience necessary and to be successful yet. So that's part of where Massachusetts, where we come in, is to try to solve these challenges. So we think of this as a funnel from from the earliest stage of company to the companies that we want to come out of this, out of the bottom of the funnel in terms of distribution. And we could think of, and our goal is to provide solutions at each area in the growth phase of a company. So, for instance, and that's boiled down to 3 core strategies for that. First is creating collaboration opportunities, and I'll talk a little bit on the next couple of slides about the way that we're doing that. Directly facilitating, startup and company and connection with their customers, and then developing a network to support firms as they scale. Because in economic development and also in just in terms of the Commonwealth's thought process around this, we really want Massachusetts to be the home for the large digital health companies. We have a great ecosystem for startups, and we want to keep that going further. So. Number one, so creating the collaboration opportunities. So there are a couple things that we're doing in here. Folks are interested. We've built a directory of all of the marketplace participants at massdigitalhealth.org. We're building and have built tools to help connect customers with entrepreneurs who can solve their problems, and vice versa. We've built a directory to help entrepreneurs find customers that would be interested in their solutions. And then we're supporting regional collaborations in some of our high potential areas, primarily around Boston. There's about 60%, 250 or so of the companies, digital health companies in Massachusetts, are headquartered in either Boston or right next door in Cambridge. And the other 100 or so companies are spread across the rest of the state, with a heavy concentration as well in Springfield, Mass, around Bay State Health. So we're encouraging those 2 centers in Springfield as well as in Boston to pull together their communities and their networks. And for folks coming to the U.S., they can be really interesting places to land, because they are you can test out your ideas with real live providers. So, and that gets to the second point around directly facilitating customer and entrepreneur connections. So we've sponsored 2 accelerators, Pulse at Mass Challenge, which is a later stage digital health accelerator. Last year we had about 30 companies from an application class of about 450 companies participate in that accelerator, so it's highly competitive. And what we found, the key point to that accelerator was we established connections between companies and, on average, 2 to 3 champion partners who signed up during the course of the 6-month project to deliver real value. And we had some really interesting and really innovative solutions in areas ranging from end-of-life care to virtual reality to sort of some really interesting devices that measured concussion symptoms and could be precursor measuring eye movement in order to help identify maybe early onset of certain disease states. So there's a whole wide range of digital health technology, some of which has some physical component, and a lot of it is software. And so folks can apply to that from all over the world. We had, I think, one company from Barcelona and another company from Israel participate in the program last year. And that program will bring folks to the US. TechSpring is a similar sort of environment, but in a hospital called Bay State Health, which is in Springfield, Massachusetts, and is more focused on our community hospitals in the US. And then Mihai, my organization, actually has a person on staff whose job it is to help make direct connections for entrepreneurs to to their customers. And for international folks who are coming to the US, his job is to help introduce them to the ecosystem and to make sure that folks can get involved to the extent they want in Massachusetts. And then last, our third area of emphasis is around supporting scaling companies. We've identified a list of the high potential, about 25 companies in Massachusetts that have a proven product and have the potential to scale, and we want to support their growth. So we're doing that through a combination of connecting them directly with potential customers, networking events, introduction to investors, and sort of helping support them. We're trying to figure this out a little bit. I think this is the holy grail for many economic development agencies, is to figure out how to support scaling companies to the extent possible. And so we're trying out a bunch of different things. So I'll leave my remarks there, and if you need to get in touch with me, the contact information is up there, and I think we've got time for questions and so on.
Thank you, Lawrence. Please be seated right next to. Yes. Hello. Just a quick question. Did I understand correctly that you in Massachusetts, you have more like business-like approach to this whole thing, and we in the old Europe, we are like privacy and human rights and whatever?
I wouldn't say that we ignore privacy and human rights, but the driver for us is thinking about how can we have a real impact on both the ecosystem, and then from the public infrastructure, we're also, we figure we'll build up the ecosystem and then apply that to some of the key challenges, the health challenges that we have. So we have three core health challenges: aging and caregiving, combating the opioid crisis, and supporting our movement towards value-based care or health reform in the US, which may be specific there, not as applicable here, but those three public challenges are what we are also applying digital technology to.
Xavier, are we a bit more kind of old-fashioned here in Europe with our approach?
I think that there are, first, cultures are very diverse. And within Europe, what you have is very different sensibilities towards privacy and protection of data. And this has to do with culture, history, all sorts of things. And also with the extent to which people have seen the benefits of technology. I'm sure that there's a direct connection between the easy way in which Estonia has introduced technology in health and the way Estonians see every day the benefits of technology in health and in technology in general. It doesn't mean that they're not cautious about other things. So I think that there's an element of cultural realities that we would be wise to acknowledge, certainly from the European Commission, because we don't have the legitimacy to overcome or to either fight these sensibilities. But then I think, listening to this extremely interesting presentation, my first reaction was, well, this is fantastic as to e-health in Massachusetts. My question is, what about e-health in Mississippi? Because that is the relevant comparison and the challenge, I'm sure, that you would see. I mean, luckily, I guess for you, Mississippi is not your immediate problem. For the Commission, we have Mississippi and Massachusetts. And bringing them together is what is critically important. Clemens Auer, in the previous panel, said something very wise. It's fantastic to have voluntary initiatives. What we have to have is voluntary commitments that actually bring all countries together. Because at least this, from the perspective of the Commission, this is what really matters. And this doesn't mean we have to go everybody at the same speed, at the same time, holding hands. That was possible when we were 6, now we're 28, soon 27. Methods can be different, but the purpose has to be to do it together. And that's what is really, really difficult with the diversity we have of culture, of capacity, of mindsets, and of technological advancement of healthcare providers.
Yeah, I mean, I would not hold out Massachusetts as middle of the pack or leading. I mean, we have advantages there that, from a business perspective, we're attempting to capitalize on, and that's absolutely true.
But this is the idea of the single market that to develop that.
Yeah, just that I think the presentations we gave were about what we gave, were fairly general. We'd not elaborate a lot on the innovation part, which is a key part of our strategies, both at member states and the EU level. And I think the two are compatible, and I think that's the European approach, preserving our values at the same time, stimulating business growth and innovation. And our business approach, or our economic approach to the digitization of the economy and society, is also about making sure that we have a comprehensive strategy where everyone can benefit from digital transformation, including in health and care. This is our policy for digitization of the economy. It is about making sure technology reaches every business in Europe, that every region, anywhere in Europe, you can innovate, create business with digital all across Europe. And that applies also to our citizens, and that applies also to our services and our public sector. The ambition is to make sure that it is all across Europe that we develop it. And innovation is a key part of what we do. I mean, we did not elaborate on that because I was retaining myself. This is the business that we ran. In DG Connect, a large part of our work is on innovation. I was retaining myself not to elaborate a lot on this. But you know that we invest today, Xavier mentioned some of the figures regarding the IMI partnership, but when it comes to digital transformation of health and care, we have an active and health aging partnership, an EIP, with the public sector and the private sector. And our investment in that partnership is around €1 billion over 7 years. And I did a calculation of how much we do in the general technology for digital that are relevant to health, and where health is a major application area. It's more than 40% of the 7-8 billion euros that we spend every year, that we spend over or invest in the current financial framework. So 1.2 billion euro per year. That goes into basic technology for health, where businesses, this is support to industrial research and innovation, where businesses are involved. And that goes from wearables and components up to data analytics. All these areas that we support heavily for business growth all across Europe. So it is a major part, and that's compatible with our policies to make sure that data is protected, that our value is protected, that health, the benefits of digital transformation of health reaches all our citizens. That's our approach.
Let's get some public questions. First, there's Anneli, who wanted to ask one question before, and she was interested in showing the patients, or you said customers' point of view. So this is very important. Let's listen.
Thank you for the excellent presentations from 3 different views. I really would like to take the patients into the picture. I'm representing Estonian umbrella for patients organizations, the Disabled People's Chamber of Estonia. And I have a question to everybody, to audience maybe as well, that as I understood, if I understood right, the final result of the digitalization should be patient with a better health and with a more control over his or her condition as a manager of the data, personal medical data, and so on. But how can we foster the transition from the old system to the new system? How can we support patients, empower them? Because probably this is not only in Estonia, but all over Europe, that not all the patients are very well knowledge about IT, about data protection. If we want to give more control to the patients, and we totally agree that they need more control over the data and over the health and the cure and everything, be it to partners as a medical system. But how can we foster them, to educate them, to empower them, to be able to take more responsibility about their health and their data?
Thank you.
So I'll start, and I'll just talk a little bit about how we're thinking about that in the U.S. broadly and in Massachusetts. So that's government's job, to build into anything that we do privacy protection and control from the control of data for the patient, to act as the voice for patients around control of and right to their data. So, whenever we require, and we are legislatively required to include for patients, that they give explicit consent for sharing of their information, for use of or reuse of their information, and we build into our regulations and laws explicit privacy protections. Some of those, you could argue, do they go far enough, or do they, are there ways to leverage that? But I do think that that is government's role to make sure that the base infrastructure includes protection of data, protection of patients' rights to their own data and consumers' rights to their own data. So I do talk about customers because we think that we're going to drive innovation when businesses and entrepreneurs are really working hard to solve problems that they can get paid to solve, rather than government suggesting how those problems will be solved. But our role is to embed into those solutions the necessary protections.
So, what is the European Commission's point of view on this?
No, I think, well, this is when you realize that the regulator is important. I couldn't agree more. This is the task of government, to make sure that patients' rights are protected, and that a principle which, by the way, we don't have to fight for, is already there, that the ownership of data is of patients. This is already there. We must make sure it's implemented. And this is, of course, not just an issue of the healthcare system. Look at the banking system. In some countries, I think of my own country, Spain, we had a huge, dramatic scandal of the banking sector not giving formally information to patients in this case, although they call them customers too. And in fact, there were lots of people who didn't have the capacity to understand what they were doing. We have to make sure that this is not the case for health. This is not and should not be primarily a responsibility for the Commission to implement in practice, but we must make sure that member states put in place, with respect to their own data protection criteria, the right instruments, in a way that still allows for the single market to function. It's easier said than done, and that is precisely why it is so difficult. This is what we're doing. We are working on the one hand with something called the e-health network that is co-chaired. I saw Clemens just coming in, Clemens and myself. That is where the technology people in health ministries get together, but then there's a parallel discussion of people who look at data protection. The trouble is that maybe they don't speak to each other enough because they function with different incentives. So this is still a battle to be fought, but it is, I think, of critical importance that this issue is not left aside. And I think that we also should rely on patients' associations to kick the backside of European and national institutions to make sure that their rights are respected. Let me add, if I may, one just small point to say that the way to actually use technology for the benefit of patients is not just by looking at their rights, but by changing the way in which healthcare provision is given. I'll give you an example of what we are working. Together with the OECD, we're working on something called PARIS, with our obsession for acronyms, Patient Reported Information Survey. This is a methodology that gives you a sense of the patient-reported experience and patient-reported outcome monitoring of healthcare systems. In other words, the experience of patients when they are confronted with the healthcare system. Because now we can measure inputs very easily, numbers of beds, numbers of operations, but you can have two operations identically successful from a clinical point of view, but one with devastating effects and the other leaving the patient perfectly happy. We have to do better there. If we manage, through technology, to have a better sense of patients' experience when they are subject to the healthcare system, then you will have informed customers. Then I will not mind if they're called customers, and then we'll be able to respond more. So this is, I think, the paradox and the challenge for all of us to see at the same time the challenges and the opportunities of what technology can do for health, The point that I keep banging on, this is my role, others have others, is that technology in health, as in else other areas, is not an end, it's a means. And the end is patients.
Okay, next question. This one.
I'm Laurie from Australia, and everything around this conference is about data protection and the patient. But why don't we turn the circle around and make that data available, for example, for disability people? In Australia, we're spending $22 billion on what's called the National Disability Insurance Scheme. And that is about services and making those services available to the patients so they can find them on the internet or on their mobile phone. And I don't see what the difficulty is in doing that. We're all talking about the hard stuff. Let's do the easy stuff. I just don't know why people just don't see that, but that's just my experience. So how does the European Union see about providing services? I come from Australia. I'm in Estonia. I don't even know where the doctor, the pharmacy, the medical hospital is. I should be able to find that on my phone.
Google.ee.
Does it have the opening hours? It's not verified or accurate or current. Thank you.
Thank you. Tricky question. Where does he find his aspirin? In Tallinn? I can tell you where you find it.
I can start, and I'm sure that Karim will continue. Well, Australia is a fantastic country. And like all fantastic countries, it's driven by its own incentives. And the incentive in Australia is distance. And this is why it was Australia that invented online education with radio phones, because you have to go really far away. So I'm not surprised that this issue of the proximity and the distance is a key issue in Australia. I'm not sure that we should look as a priority from that angle in Europe, because there we have other challenges. We have a challenge of equity in access, not so much a challenge as you describe it, I think. Not that this is not important, but this is, I think, perhaps less of an immediate issue that comes to mind.
Yeah, I think the service offered, as I understood well from Australia, is the provision of or making the health data available for everyone to look into. I think there are things like that exist in the Union today, but it requires, I would say, work on the packaging, preparation of the data to make it available. But it's a good experience. I'll have a look at what's happening there. Might be interesting. I do think, though, it's something that member states. I mean, this is something for the member states to look at. But I'm interested to see, what can be done in Europe in that perspective. Why not?
And Lawrence, do you see in the US that this Massachusetts model would kind of spread around the states?
So, will the Massachusetts model spread around the states? It hasn't yet.
Would you like it to?
Yeah, I think it would make sense to, but I lead the only agency that I'm aware of. There's one in New York, but most of the U.S. doesn't have a similar sort of agency. Now, it could be that many of the other states don't have the sort of the concentration. We look at it as, look, we have some natural advantages from tech and hospital delivery and so on, and we're trying to combine those. So other states may not have that capacity, so it may not make sense, but it would be interesting, and I think there would be value in encouraging the development of e-health and digital health more broadly than just in Massachusetts.
Thank you, gentlemen. The time flies when you have fun and interesting speakers. So we'll continue with the conference later in the afternoon. Let's have a round of applause first. Thank you. And we'll continue the sessions in 15 minutes. Here, citizen-controlled data governance and data donors and Power Station will host a moving toward outcome-based healthcare, thanks to digital, and also in Steam Room, convergence roadmap of interoperability standards and so on. So please attend and be involved. Thank you.